Thanks for joining us this morning. My name is Dawn Mautner. She, her, and Aya are my pronouns. I serve as your chair, also as the Medicaid Medical Director for the state of Oregon here at the Oregon Health Authority. Thanks for being with us. Let's go ahead and call the meeting to order. And I'd like to go ahead and take roll. If you're with us, feel free to join by video, especially those members of the board who are with us. And let's go ahead and get started. Siobhan Martin, are you here with us this morning?
I am here. Good morning.
Good morning. Thank you. Siobhan serves as our vice chair. Greg Klauser, are you with us this morning?
I am here.
Thanks, Greg. Feel free to do whatever makes the most sense to be safest in terms of being on or off for paying attention to video. Thank you. Chika Flowers, are you with us this morning?
Good morning, everybody. I am here by video.
Thank you. Good morning. Andrea Fultz, are you with us this morning? Maybe we'll come back to Andrea. Kimberly Hendricks, I see you on video. Good morning.
Good morning.
Sean Parkman, are you with us this morning?
I'm here. Good morning.
Morning, Sean. Emily Wong, are you with us this morning?
Yes, I'm here by video.
Good morning.
Good morning.
Rep Nose, I see you on video. Thanks for being with us this morning.
Here.
And back to Andrea Fultz.
I am here. Thank you.
Good morning, Andrea. All right. And that gets us on to it. Thank you. Board members, have you had a chance to take a look at the minutes from, I think we're looking at October's minutes.
I've had a chance to review the minutes in the packet, and I'll make a motion to approve the minutes. This is Siobhan Martin.
Thank you, Siobhan. Do I have a second?
I can second. Greg Klauser.
Thank you very much. That's an approval of the minutes. And I think that gets us to our next item on the agenda, which is to discuss the RFP. And I will take this opportunity to remind all of our participants this morning of the need to maintain an RFP, request for proposals process that is intact with integrity. That means that that participating in this meeting needs to be specific and limited, particularly around those who may be applying through this RFP process, to ensure that there is a level playing field for all of the applicants. That said, we are looking for some very specific insights from some of our current partners, and I look forward to those updates from our partners. And with that, I'd like to hand it off to those who are going to be discussing the RFP topics this morning: Brian Olson and Ruby Castaneda from staff, Andrew, Emery, and Maggie from Mercer. Who's going to take lead this morning, please?
I think that I am. I don't see anybody jumping in to correct me. Hi, Don. Hi, board members. I can open it up here, but like you noted, a lot of us will be chiming in and leading this discussion, both from the Mercer and the staff side, but glad to be with you today. If we want to jump ahead to the agenda slide, I can just make a couple of sort of quick introductory comments on where the discussion is intended to go today. We have about an hour and a half for this presentation. In the first part of the presentation, we'll be focused on the structure of the RFP, which is largely around how do we build this RFP to achieve PEBB's goals and objectives. There's some process components as well we want to discuss with you. These are around logistics, around how we're going to review bids, how do we identify deficiencies in those bids, how do we respond to bidder questions. We're going to review some proposed scoring and weighting methodology for those bids as well. And so together, Mercer and staff have drafted proposed weighting based on what we've heard from you all over the last months and year or so. And so we'll get your reaction to that. And then we will also revisit RFP roles and board evaluation and what you all want that to look like. We talked about this a little bit during the retreat. There was a good discussion at that time, but a lot of questions. And so we've taken those back and done some work. And we think we'll be able to sort of present a more clear picture of what that looks like, both the pros and cons of different evaluation designs, as well as things like time commitment for the various roles that we'll ask you all to volunteer and fill. And so with that said, I think we can proceed to slide 5. Okay, thank you. And so we wanted to start off with this purpose statement. This is a very high-level purpose statement, and the intent here is really to articulate what PEB is trying to achieve with this RFP. And so again, from a very high level, PEB is looking to identify vendor partners who are focused on high quality, both outcomes and service, best-in-class medical and pharmacy programs, and really the ability to demonstrate aligning with PEB's values. And so we're not going to get into PEB's values here in this presentation. Those will be very clearly articulated in the bid document. And so that'll be a big focus of evaluating these proposals. Getting a little bit more specific, PEB is seeking self-funded proposals for the broader network plan. This is the statewide plan offered across the state, but really across the country. And then for the more managed coordinated plan proposals that PEB is requesting, we are recommending that those be submitted either with a fully insured or a self-funded funding basis for those proposals. And so doing so provides a little bit more flexibility. And, today PEB has both funding methods, right? You have both self-funded and fully insured proposals. And so allowing those proposers to submit either funding mechanism with the more managed coordinated care plan just gives PEB a little bit more flexibility when it comes to evaluating those proposals. And then at the end of the day, the intent is for PEB to select up to one vendor to administer the statewide plan, as well as one or more vendors to administer coordinated care plans, which could be across the state. They could be more limited in geography. And so that will shake out, and that decision will be made once the proposals are in hand and the evaluation is done. And so again, this is a very high level purpose statement, but I'm going to pause here and see what comments and questions board members have.
Andrew?
Yes.
Could you give me, just because I don't know in the previous, how this compares to what the purpose was of the previous RFP?
Yeah, so this does align in many ways with the previous RFP, and we are going to talk about that history a little bit more in some subsequent slides. There are some nuanced differences. In the last RFP, I think there was only one carve-out pharmacy bid that was accepted. We are recommending that be opened up to other bidders. So there are some differences, but in many ways there are similarities. I don't know what was designed from a funding mechanism perspective in the last RFP. I'm guessing it was the same as this, given that PEB's current cares are both self-funded and fully insured. But we'll get into a little bit more of the nuance and the differences from that RFP from like 10 years ago. So yeah, great question.
Thank you.
Rep Nose.
Do you feel like you need to say best-in-class medical and either mental or behavioral health, or is that getting too granular? Because I feel like if you want to improve that particular aspect of the benefit and the delivery system, it might be useful to have that phrase.
Yeah, that's a great point, and something that we wrestled with a little bit when we were on this slide. We even thought, maybe we should really articulate what the values are here and get into some of that detail.
No, and then you go down that rabbit hole and it's a 20-page thing.
Yeah, and I do think that some of that detail will be in the actual bid document.
Okay.
And so this is a little bit of an abbreviated version.
I don't have strong feelings about it, but I think for most of us, I think we're trying to have mental health behavioral health be part of medical in our brains, but I don't know that we're there yet.
Yeah, that's a good point. Any other comments or questions before we get into some of the other other content? Yes, Emily.
Yeah, I just really agree with that proposal actually with that Repnos was asking us to explore.
Yeah.
Because I know in my PhD program at one point Greenlick had come to speak to our class about how when he was first envisioning health systems transformation for Oregon, the that he wasn't always thinking of behavioral health, mental health at that time, and so really wanting to be more conscious that that is included, with physical health and dental and oral health. So, it might be helpful to call that out, especially since it's such a high priority for Oregon from our governor, to Oregon Health Authority, behavioral health, mental health transformation.
Yeah, I agree with that statement. It's definitely been a focus for PEB across the state, and there's still work to be done to make sure that it's understood that this is a part of physical health. So yeah, message received. We can adjust this to include behavioral health and still try to keep it concise. And then there'll be more detail, I think, in the actual bid document so that it's clear to all bidders that that is a high priority for PEB. Yeah, good comment. Any other comments or questions on this statement? Okay, not seeing any, so I will pass it off to one of my colleagues. Emery is going to spend a little bit of time talking about similarities and differences between that prior RFP, as well as getting a little bit more specific on the structure of what we're proposing with this RFP. So Emery, I will pass it over to you.
All right, thank you, Andrew. So, so the next few slides, we'll get a little bit more detail, more granular about the actual process and how the RFP is going to be laid out. We will get into the scoring, and I think when we get to the scoring, we definitely want to hear feedback from the board. I think highlighting behavioral health will be pretty evident there, but in terms of the types of topics, the types of elements of healthcare delivery system is going to be reflected there, and so we can have that discussion as well. But generally, in terms of the structure of the RFP, because we are talking about essentially multiple elements where we do have the medical portion where bidders can bid on the medical only, as well as pharmacy only. There's going to be multiple RFPs, including, the different locations and types of plans, medical plans that PEB currently has, and we are including in this RFP. So again, so similar, a lot of the structure is similar to what was done back in 2013 for the 2015 time period plan year. So we will have essentially a statewide, which as Andrew mentioned, is really not quite statewide. It's called statewide, but it's really national. And this is more of an open PPO, more bigger, wider network plan that allows members to have a little bit more choice in terms of the providers that they're going to. This will be, as Andrew mentioned, up to one bidder would be potentially accepted for this. We're not having multiple bidders for this open wide net or winners for the open wide network, but we will have up to one that's selected, and that's going to be one portion of the RFP. So the other portion of the RFP would be essentially what we would call the coordinated care plans, essentially the Providence Choice, the MODAs, the Kaisers, so a more highly managed provider network. So the network is definitely going to be, in this case, as we mentioned, it said before, like more curated, more tightly financially connected, with much more medical care coordination with behavioral health and all the other elements. Those criteria we're going to be talking about later, but these could be regional, essentially smaller regions depending on the footprint and the types of the providers and the networks and how they want to create that plan. It can be self-insured and fully insured, but they're going to be potentially in smaller regions. For example, Kaiser's in essentially the metro and the I-5 corridor down to Eugene. It could be that type. It could be wider across the state, or across the state plus other border areas. One area where we did talk about where it's a little bit different from the 2013 RFP is for these coordinated care plans. We will also be asking about essentially extending the plan design, the plan region, not just through Oregon and the border regions, but potentially to other locations. Because as we talked about in the retreat, there are members across all 50 states, and trying to give those members potentially the choice of having, not just a PPO, like a statewide plan, but also this tighter, more coordinated care plan where you have a little better cost sharing and potentially lower contributions. We want to see what's available. The requirements will be very, the same with the coordinated care in Oregon. It's essentially one product that they would be bidding on, but we would be looking to see if they can create essentially a medical home type of network. It's not necessarily going to be the PCPCH, exact requirements on the medical homes, but something very, very similar. So basically, how close can you replicate that outside of the state to give the choice to the members? So that's a little bit of a difference from what was done for the 2013 RFP, but essentially we would have two different types of plans that would be that bidders could propose on in this case. With that, I will pause to see if there's any questions or comments, or if anything, Brian and Ruby, if there's anything that you wanted to add in regards to essentially the splitting out of the medicals options. Okay, moving on to the next slide. So pharmacy is obviously going to be a big portion of the RFP. Pharmacy costs continue to increase. It's like about 20% of the overall cost, depending on which plan you're looking at. So similar again to the 2013, there's going to be the option of essentially having a combined proposal. In this case, a medical and pharmacy combined together with the integration of the pharmacy into the medical. You can also propose on the medical only portion, which was bid during the 2013. There were plans that only bid the medical only. You can bid either medical pharmacy combined or medical only, or you could bid both. So it's not necessarily you have to only bid one or the other, but you have the option there. So if you bid a medical only proposal, the pharmacy would then be potentially brought in from the pharmacy only RFP portion. So we would be going essentially to opening it up for all of the pharmacy benefit managers to potentially bid to try to get the best in-class services and pricing for PEBB, because the 3.4% limitation obviously is a big thing. And the pricing is going to be a large portion of that, as well as the formulary and other things. But, trying to be the best fiduciaries for the PEBB plan. We want to see what's available out there for PEBB in terms of best of class pricing and pharmacy benefits. So there's also going to be a pharmacy only RFP that's going to be evaluated again like a separate mini RFP. So those bidders will come in, they'll make their offers. There will be analysis of that, and then there will be essentially scoring and ranking of the pharmacy only options. So what does that mean when we are talking about bringing it all together with the health plans with the medical portion of the RFP? So for the combined medical and pharmacy, we will be evaluating the pharmacy as well. And then that obviously will be with the medical portion of it. And then the overall score for that would be calculated and determined. For those who are bidding medical only, essentially the pharmacy only scores will be combined with the medical only scores. And then we'll show the weighting later on, which is essentially 80-20. But essentially, you would have a combination that would put you on the same basis as the medical pharmacy proposal. Those medical only bidders would be, replying only to the medical portion of the score. They'd be relying on the pharmacy bidders to do their portion of the score. And then overall, that will be combined. There's going to be some winnowing of the pharmacy scores, because potentially there could be 10 plus pharmacy bidders, PBMs bidding. So essentially, we might be cutting down what we would say would be essentially the top pharmacy scores to kind of combine it together. So we won't have a whole bunch of different combined medical only and pharmacy only scores, but we will be looking at that. But overall, the medical only would be relying on the pharmacy only to get to the combined scores. And so that combination of the medical only and the pharmacy only would also be compared against the medical and pharmacy combined. And that would essentially be your entire universe of potential bidders. So that's, I don't know, more than the mouthful. We can go through that in a little bit more detail. Sean, you have a question?
Yeah, just clarify that point. So
Mhm.
if a medical proposer has a preference for which pharmacy you know, system, then it would benefit them to, in my understanding, right, they would apply together as if a medical and pharmacy, it would be like a joint thing. If
Yes.
they have no preference, that's when they would just do a medical only, and then like the presumption is they would be fine working with whoever. Is that the idea?
Yes, that is the idea. So just based on prior history, what happened in 2013. So Providence bid with the Providence Pharmacy, Moda bid with OPDP, and Kaiser bid with Kaiser Pharmacy. There were also Kaiser did not bid with medical only. You know, their integrated system with the pharmacy, so they had their one bid. I think I'm not going to say about Moda because I think they only bid with OPDP, but I could be wrong. But I believe Providence also bid on medical only, saying that, you know, they think their pharmacy can win, but, you know, for the option, they wanted to do the pharmacy only. There were also other bidders that bid medical only, and two of them were selected, All Care and Trillium, that only bid on the medical because the pharmacy, whatever that they could do with the pharmacy was maybe not as good as what was OPDP. So they were willing to accept OPDP and to work with OPDP for their overall medical plan. And so in that case, they did end up winning, and they worked with OPDP when they were serving PEB in this case. So it is up to the proposers to say, hey, you know, maybe our pharmacy is the best. We want that integration, so we're only going to bid, or we're going to bid with the pharmacy combined, and give that offer and try to win with that. But if they don't feel, or they feel like they could work with whoever's winning, then they could also offer a medical only proposal.
Okay, so in our current scenario that we're describing here,
Mhm.
we're allowing that. So in other
Yes.
words, a proposer, a medical proposer
Mhm.
could submit twice.
Yes.
Once they could submit a proposal with a fully integrated,
Mhm.
pharmacy, and then they could submit again just in case or whatever,
Yes.
to keep their options open. Okay. All right.
Yep. That's the case. Mhm. Yep. So as mentioned, I think that's really to the final bullet there, right? It's like you can bid both ways, you know, potentially if you want to increase your chances of winning, you know, you could bid medical only as well as medical pharmacy in this case. Okay. Any other questions? All right. So in terms of a little bit more again about the process, so there will be minimum qualifications, minimum requirements. That will help, you know, that will, if you're not meeting essentially the minimum requirements, then your bid might be tossed out in this case. There will also staff and Mercer mostly will also determine responsiveness to the RFPs when they are brought in. So that's essentially, are they actually responding to all of the questions? Are they being on point to the questions? You know, and also, you know, providing the information that's being asked for. There may be, you know, that potentially could, you know, result in a bid not qualifying if you're not being responsive. There's also the chance to potentially go back to the plans and asking them to essentially modify their responses to be, to be actually on point with the RFP in this case. That process, the minimum qualifications is essentially the first cut. Once we get the RFP replies, that will be similar for statewide and coordinated care plan. So, in terms of the entire process, we're going to be running it very similarly in this case. And Brian and Ruby, please, if there's any other color commentary points you want, please interrupt me as you are running this process. So, as mentioned, Mercer will be reviewing most of the information to determine whether they are complying in this case, and then provide it to staff. And so, again, whether there's potentially any issues with it, there could be updates. Otherwise, the proposals could be disqualified for not being responsive, essentially, to what PEBB is asking for.
And just to, this is Ruby Castañeda. I'm the, I'll put myself on camera so that way people can see me. The omissions and stuff, a lot of that will also be part of the work group that we will be requesting some board members to assist with. So that way we can ensure that we feel like the board will be comfortable with some of those proposals that are going to be disqualified. So, yeah.
Thank you. Okay, so that is essentially the initial review. There's going to be scoring, which we're going to have in a separate section where we're taking a look at it and scoring, and then but I think the next slide really kind of jumps really to the evaluation, and then essentially the finalists, selecting the finalists in this case. So again, as mentioned, more detail will be provided on the left section, which is the evaluation and scoring. But essentially, these are the proposals that would be evaluated and scored. So you would have the pharmacy only portion, so that would be done by Sarah Drake at Mercer and her team. The medical only portion of the bidders, so the bidders who only did the medical only, that'd be evaluated and scored. It's kind of similar with the combined medical pharmacy. So the medical portions of those would be scored and evaluated. The pharmacy portion of the combined and medical pharmacy would be scored by in addition to the pharmacy only, but essentially all of those proposals that are being offered would essentially, we would look at the scores, kind of compare the questions, the medical only questions to the medical only, pharmacy only to the pharmacy, medical and pharmacy questions, and then scoring across the board to make sure everything's on this similar basis here. So those, that process will take place. In terms of the financial components of it, the pharmacy financial information will be evaluated by Mercer. The medical portion would be also evaluated by Mercer. And then those expected costs would be kind of combined to develop premium equivalents. The reason, essentially, funding rates based on the proposals. The reason we're doing this is because for the fully insured plans, they would be essentially proposing a premium rate, the rates that they would charge to pay to have for the entire plan, for the plans that they're offering. And what we want to do is we want to compare the financials of the self-insured to the fully insured plans. And so we'll essentially create premium equivalents for the self-funded proposals compared to the fully insured proposals. And that's how we're going to score it based on that comparison. That's, again, similar to what was done in the 2013 process, where we're just trying to keep everything on the same basis. Sean.
So, recognizing I'm at great risk of potentially hitting a horse that's already down, but just a question. Is it a thing, back to Representative Nosa's question, is it a thing that there are essentially the equivalent of a pharmacy benefit, manager for behavioral health? Like, is that a thing? And if so, would it benefit us to have like the options here of like pharmacy only, medical only, combined medical pharmacy, behavioral health only, behavioral health and medical, you know what I'm saying? Like, is that worth that, or is that so rare at this point that that's just kind of not worth it? Just a
Yeah,
question.
so I think there's definitely there's different ways of looking at this. I think you made Ruby and Brian's head just explode based on the number of different breakouts you're talking here. It does add to the complexity quite a bit if you break out behavioral health in this case.
I
I
also
will,
wanted to
yeah,
add,
go ahead.
Emery, real quick, that we will have behavioral health questions inside the RFP as well, in terms of like how they case manage their behavioral health and stuff like that. So a lot of the information in terms of behavioral health, as well as diversity, equity, and inclusion, are all within parts of the different layers of the RFP. And so it will still be scored and evaluated. So I just want to make sure that the board members are well aware that a lot of the information is very inclusive to not only include medical, but behavioral health, as well as diversity, equity, and inclusion, as well as network and financials that Emery had mentioned as well. So there's a lot of information within the RFP that they will need to respond to, and that information will be scored and evaluated as a whole. So just wanted to make sure everybody was aware of that. And also to let you know that just because you're bidding on medical only, and then you're also bidding on medical pharmacy, the information in terms of the questions are in alignment with one another. So you're not going to have any diversions of, okay, medical only, they'll just only have the pharmacy portions, they're just not going to respond to the pharmacy portions of the information. But the medical pharmacy, they will respond to all of it. And then the pharmacy will also respond to just the pharmacy portions. But the information and the questions are going to be identical, and those responses are going to be carried over in terms of the combined medical pharmacy. So I just wanted it to be clear in terms of that, so that way we have accurate scoring and rankings when it comes to the finalists. Does that answer any additional questions that anybody may have? And then Emily, I saw your question in the chat of who's leading evaluation and scoring for medical only and combined medical plus pharmacy. So the medical only, as well as the medical combined, a lot of that's going to be, some of that information is going to be, board members are going to be asked to evaluate. If you're part of an evaluation, you will be asked to evaluate those. And then in terms of the pharmacy, we're going to actually rely heavily on Mercer and their expertise in their scoring for that information. I hope that answers your question. Thanks.
Thank you. Thank you, Ruby. Yeah, so Sean, I think your question about essentially having, an entity that's just managing behavioral health, I think we'll try not to go down too much of a rabbit hole here, but I think Christy has just a little bit of information she might want to talk about on that, just to give you a little background, but
Thanks,
not to
Emery.
divert ourselves too much. Go ahead.
I just wanted to add, so industry-wide, what we've seen, there are some like behavioral health carve out or separates, but we really have seen organizations move away from that over the past 5 to 8 years. Because typically what we found with organizations that had separate kind of behavioral health services was that it was a messy user experience of trying to figure out where to go for care. And with mental health parity, there also are some considerations there. And really now we're seeing the industry really move towards this, what we all have been talking about is the integration of medical and behavioral health is so crucial to treating the whole person. And that's really hard to do when there's kind of a separate kind of behavioral health component that's not integrated within the medical plan. So just wanted to share kind of that broader industry trends that we're seeing.
Thank you, Christy. And just to sum up, it feels like pharmacy lends itself more to being carved out and still ensuring that integration versus behavioral health is just a different dynamic, right?
Emily.
Yeah, I don't know if I'll be articulate enough, but I sort of I think this is a really great question that Sean has asked us, and thank you for the insight, Christy, like from like the bigger picture industry. I'm just thinking of like previous conversations we've had here at the PEB board meetings about these trends that we're seeing, and maybe they're anecdotal. I don't know if you know if anyone's done like a formal assessment statewide, but in Oregon, like the stories I keep hearing from like LGBTQ plus folks and trans youth, once they've found a therapist that is friendly and responsive to their needs, some of these therapists are leaving the big insurance company groups because they feel like there's too many limitations put on them in terms of what they can talk about or not talk about. Or, I mean, again, this is just anecdotal. It's not, but I just keep hearing more and more stories like this. And so they're leaving these insurance networks. They're even leaving these like smaller clinics with multiple of them to do their own thing so that they can like serve the trans youth, for example, the way that they believe that they should be served. So, you know, I am paraphrasing and I may not be accurate, but I just keep hearing these more and more of these stories, and I'm just hoping that through our RFP process that will be taking account of that, because behavioral health reimbursement and medical, you know, health reimbursement is really different. And, you know, there is this, I've been in some meetings lately where people are saying, how can we help our behavioral health providers do the work that they are practiced and experienced at doing without them living in poverty? And so, you know, and again, these are just little anecdotes I'm hearing here and there in different meetings that I've been in, you know, in the last month. And so I don't know if that, I'm not trying to complicate things. I just want to make sure that that's informing like our decisions that we make with this RFP.
Yeah, and thank you for that, Emily. Those questions are definitely ones, you know, or those issues are definitely going to be questions that we're going to be asking, you know, those types of questions in the RFP itself. And when we go to essentially allocating points, you know, scoring and weighting for the importance of that, you know, those kinds of questions, behavioral health, you know, health equity and all those other elements, and how, you know, how they treat diverse populations and how they, you know, make everything, well, as equitable as possible. Those are going to be questions that are going to be key. And I think, so they are definitely very, very important. I think we'll actually, I want to kind of pause on that, because I think maybe we should start with the scoring section first rather than the process, and then a lot of these questions be answered. But I think hopefully when we get to that section, you'll see part of what we're trying to achieve, and that we're hopefully meeting your what you're seeing as the ideal, and getting to it. You know, maybe we just, you know, having your voice is good. You know, having that voice would be great to, you know, help shape the RP. And so these kinds of topics, yeah, we'll want to have address the questions and things like that for the process. And hopefully what we show in the next section will actually kind of show that. Rep Notes.
I would just say anecdotally, a lot of behavioral health providers I know, it's not, they just don't want to have the hassle with insurance, and they can find you know, they can find people to serve who are willing to self-pay. And, you know, I think it's hard to, I don't know, maybe it's not hard to structure in the RFP how liberal are you about your onboarding process and your billing process, and how much hassle do you create? But the tension will be for us is that, I'm just going to say it in a very negative way, the easier we make it to access your benefit, the more it probably gets used, particularly in the behavioral health space. And then here we go.
I
Yeah,
can
so
help
go ahead.
with that, Emery. So a lot of that information will be pretty much in the operations of how they operationalize their network and how they do their prior authorizations and referrals. So some of that information will be in and standard questions that we will be asking in the RFP, because we don't want to make barriers where they're not necessary. That's just administrative burdensome, not only for the carrier, but it's also an administrative burdensome for the health plan as well. So being able to have those questions within the RFP of how they operationalize and how they do their credentialing or onboard a provider, and how easy and seamless it is, that'll be also key. So I hope that answers your question.
And we are taking note of all of these comments. I mean, they will help inform the types of questions that we that are written and asked of the bidders. And questions like yours, Rep. Knows, I think those, it's probably going to be an RFP. It's also potentially, I mean, that's like a very good finalist type of question, interview type of question, just to make sure that they are meeting what the PEBB board is asking of for the plan. So definitely we'll note that.
I'm so glad I'm not going to be a part of this process, because I'll be in session. Do a good job.
Yes, sir. Go ahead, Emery. Thank you.
Yes. Yeah. Okay. So just kind of, I think we are kind of, so just to talk about the scoring process and the finalists, I think we kind of talked a little bit about it. We're adding all the scores together. We'll combine them, compare them in this case. So once we get that final ranking, we will take a look to see who are essentially the highest scores, see if there's any natural breaks in the scoring, and essentially create a list of potential bidders who might be essentially, we would say, qualified to be finalists. In that case, we will bring that to the board for the board to essentially say, yes, this is a good list of determining finalists, as you can see down below. And then from that point, those potential finalists would be essentially invited to finalist interviews to essentially get final, to the board to really ask the questions, to interview them, and to see, who might be meeting the PEBB board's needs, as well as, adding those scores to the final ranking. But
just to note, Emery, just for
yes.
clarity, we'd already talked about having a subset of board members be actual evaluators. When we're talking about the recommendations for who the finalists will be and actual winners, I just want to be clear that that's going to be the full board, minus any board members who declare conflicts of interest, right? They'll still be able to be, I think, listen in on the conversation, but not necessarily have a vote, depending on what kind of conflict it is. So those big decision points are kind of a full board sort of decision.
Yep. And so essentially the next two slides, or this slide and the next slide, talking about the finalist interviews, and then actually voting on the winners, it would be to the full board in this case, based on the process I think we had been talking about in the retreat and have come up with. So in terms of finalist interviews, the points, there's going to be a separate process for the finalist interviews once they show up. So again, there's, you could bid on medical only, medical plus pharmacy combined, as well as the pharmacy only bidders. The rank points in finalist interviews is going to be essentially, again, it's going to be essentially similar, 80-20 weighting between medical and pharmacy. So those who are bidding on medical and pharmacy combined would have 100% total points. Those bidding medical only would essentially be able to get 80% of the points, and they'd be combined with the score of the pharmacy only finalists, which is the 20%. So the weighting's the same, but essentially the medical only would be relying on the pharmacy only for the 20%, but the medical and pharmacy would be able to answer and get points for about 100%. Those finalist interview scores will be combined with the written portion of it. Right now, the weighting that we're anticipating is 75% written, 25% finalist interviews. And so that would determine the final ranking. The one point is that we're thinking about having a best and final offer opportunity for the finalists. So prior to the finalist interviews, having the finalists go back and taking a look at their proposals and seeing if they can improve some of certain financial elements of it. The 3.4% limitation again, is very, very important for PEBB, and then allowing those finalists to essentially come back with a best and final offer. And then we would potentially change the scores based on their best and final offer, but it's another chance to essentially improve their ranking or, their offer to PEBB in this case. And then once the scores based on the finalist interviews and the written proposal with the best and final improvements, that creates a final list that essentially would be going to the board for the board to essentially vote on who might be the winner. There's going to be some additional criteria that we'll talk about, but the board would be able to vote on that. Sean.
Just a process question. When the, I don't know what y'all are wanting to call it, but let's say the pre-review process, the smaller set of board members that are kind of doing the initial scoring, whatever that's called. How does it work? To what degree do those members have the ability to ask follow-up questions or clarifying questions or that sort of thing with the proposers?
I don't want to get myself into too much trouble. I have an opinion. I think I have the answer for this, but I'll let Brian and Ruby take this one because I think this is more in their court.
Okay. And then Ruby, feel free to jump in. So generally for all evaluators, part of the process is if you're reading responses and based on how they're written, they're not really speaking to the question and you feel like you need some sort of clarification in order to actually evaluate that, the RFP will allow for a process that will build into the RFP where evaluators can let Ruby and the team know. We'll reach out to proposers, get clarifications as needed. Obviously, we try to minimize that by on the front end, making sure they're responsive and they actually, speak to the question that's being asked rather than provide other extraneous information that may not directly answer the question. But inevitably, we're talking a big, large, complex RFP, and inevitably, I think clarifications are oftentimes needed. So we'll try to minimize them, but there is that ability to clarify certain responses during the evaluation process. And then also, kind of related to that, there'll be a feedback loop for where board member evaluators can maybe share some of their concerns, questions with the RFP team and Ruby, and that information can be used then to design the finalist interview questions. So there's another opportunity to go back to certain proposers who are selected as finalists and maybe ask them to, elaborate or build on certain information in their proposal.
Ruby, did you want to?
No, I was just gonna reiterate what Brian said. So yeah, no, I think we're good. Thanks.
Okay. Okay. Yeah. So just kind of to reiterate, I guess what's on the slide, general rule, the board must select the highest scoring proposers, except there are potential criteria that would allow a little bit of flexibility, which is on the next slide. So the flexibility is to essentially get at the values, the elements that the board finds most important. And the ones that we have come up with for now is to essentially, based on if you're within 2.5 points, percentage percentages of the points total that the highest ranked proposer has, at least for the statewide plan. In this case, if you're within 2.5%, if you have a higher scoring advocacy program in terms of the questions tied to advocacy, and your scoring in that's actually higher than the highest ranked, then potentially that could be a criteria where the board could go, hey, you may not have scored as high, but we like your advocacy program better, and so we're going to vote for you there, and select you. There's another option with disruption as well, because based on what the comments during the retreat, disruption is a huge issue for PEB. If the disruption is going to be less for PEB, that would essentially allow the PEB board to vote for a lower scoring proposer and to be the winner in this case for a statewide plan. There's also another potential exception criteria to kind of because OPDP or Array RX is part of a state plan. If the lower scoring proposal is within 1 point of the higher ranked proposal, and the lower proposal includes Array RX as its pharmacy provider, then that's another potential criteria that would allow the PEB board to select that plan. So these are or options. It's not and. So if some of these are potentially met for a lower scoring proposer, then PEB board would be allowed to vote and select them as the winning statewide plan.
And I would just
the criteria
add
for
that,
coordinated care is a little bit different, but Brian, go ahead.
Yeah, I would just add, we're really looking for your reaction to these concepts here. Because again, what we're getting at is all else being relatively equal, there may be some things that are important enough to the board to reach down and select a lower scoring proposal over a higher one. That said, in full disclosure, there's a lot more complexities behind this process that we still have yet to build out, because first we wanted to run it by you to make sure this is something that you generally agree with in concept. So one complexity is, for example, if there's 3 or 4 finalists within that 2.5 point threshold, how do all those exception criteria all of a sudden work? We'll be working that out with Mercer, but first, before we devoted all that time and energy to figuring out all those permutations, we really wanted to get your reaction to whether the board felt like this was hitting the mark.
And if you want to think about it while we go over the coordinated care plan selection criteria, please do so. But there's a few more minor elements. Emily, go ahead.
Yeah, could you just remind me about the advocacy program part and just what all is entailed there?
Yeah, so the advocacy program, it's going to be certain elements of the member experience and a few other things where there's going to be some questions to improve the member experience, improve the navigation through the healthcare system, just trying to keep essentially help it make it easier for members to understand the conditions, coordinate the care, and to move through I don't know, it's like some things are like scheduling, but it's like also finding the right providers, helping maybe some with the transition from when you're being discharged, some additional help there, or dealing with like family members and like finding maybe community based resources, other types of other non-traditional resources where, like it's not necessarily going to be something easily found, right? It's just getting them to get better, like find the right resources and just helping them understand their plans and stuff, not just the plans, but their medical conditions and their journey. So it's going to be a lot of different questions around just improving the member experience that we're going to denote as advocacy type of questions. And then there's going to be a separate score that allows you to see like, well, now how do these plans rank against each other on these types of questions in this case?
Okay,
I'm sorry. I also wanted to add that it's also informing members of the different benefits that they may not be aware of as well. So it's also that.
Okay, thank you. And would it include, like, I know we've talked about in the past in these meetings, but when the parents have a child that turns 18, and then all of a sudden there's new rules and consents and forms and things like that that the parent and the child need to fill out. Like, would that be under there as well?
I think what you're referring to may be at more of a clinic level versus a health plan level.
That's true. Okay.
So yeah, okay.
Okay, I just know it's been a big headache for a lot of parents of children who turn 18, and especially if they're right in the middle of a treatment plan, and all of a sudden now you have to go to the child for all the permissions, and the parent can't weigh in anymore. So that's just such a pain point. So I just wanted to see if that would be included. Okay.
Yeah. And I know that for behavioral health, I think it starts at 13 versus 18. So
okay.
yeah, some clinics,
didn't know that.
I believe it's at a earlier year in life for the child that they have to go ahead and start signing their own HIPAA forms and consent to release form of information and stuff. So I know that it's younger than 18 in some areas. So just letting you know.
Oh, thank you for letting me know. I didn't know that. Oh my goodness. I have some concerns. Okay, thank you.
Sean, you had some questions?
Well, just in reaction to the question on the board here, which is, you know, what do I think of these criteria? So I think it makes sense, and I'm seeing the coordinated care one as well, so I'll include my comments here. So I think it makes sense to have some. I just want to recognize the difficulty, the challenge that you know that we face. Mercer and also PEB staff. That we need to be transparent, and we need to be. There needs to be a pretty strong quantitative component to the selection process, and that's about fairness and transparency, and all that makes sense. And so what we're seeing here is a little, nuance, because when you try to I have been part of many selection bid processes that are purely quantitative, and you can end up with some very unfortunate answers because you took out the kind of human element. You just tried to make it super quantitative, and you kind of end up with like, yeah, technically yes, but there's this whole problem that didn't show up in the exact scoring. And so in my mind, so I'm trying to balance those two things, and that's what I'm seeing is that this is an attempt to keep some guardrails on the whole thing and also allow some nuance. So I appreciate that. And I guess I'm also just saying that in my mind, a big part of the work related to the scoring, the quantitative scoring, has to do with the pre-selection process. So that, there's a chunk of applicants potentially who are just clearly not appropriate for our selection process. So they're just like, you know, in a different league below the others. And it's just like, okay, so we're not gonna move forward with these. That's a bridge too far, perhaps. So then you end up with this group that is of higher interest. And among them, they will have a score too. But then there's a bit of nuance between them. So for example, I could see a scenario where there's an applicant, a proposer who is kind of so-so. I mean, they're fine related to some of the bread and butter medical stuff. It's fine. Networks, nothing out of this park. And so they're kind of like middle of the road-ish there. But they're proposing something. Let's pretend I'm just making this up. They're doing like they figure out a little trick related to behavioral health. They're trying a new thing, and it's kind of like, oh, that's interesting. but that may not quite show up in the score, exactly, but it's the board's interested. And so that's kind of the interview part where there's like, tell me more about this thing. And so yes, it needs to be accountable, it needs to be quantitative, and also there's a little bit of that sort of inexplicable, like difficult to quantify thing when you get to the final interviews, where it's sort of like, oh, there's a thing that they're doing that's at least potentially interesting related to a hard problem we've had for a long time or something, or maybe someone, I don't know, has some sort of guarantee scheme or something for 3.4. I have no idea, but just like whatever it is, there's a little nuance. So I think this is a pretty good crack at trying that, but I've just like, in a way, trying to keep a few options for that kind of interview phase to like when it makes the final decision. Like there were reasons, but they might be uh difficult to quantify exactly. That's all.
Yeah, gotcha. Okay. Yeah, in terms of, we've had some of those discussions. I think the weighting on interview questions, finalist interview versus the RFP portion, that's, if there's more weight on the interviews, that would potentially might be what you're asking about. But we'll definitely take it back and discuss a little bit further in with staff and bring it, I don't know, with the work group as well. Dawn, did you?
Thank you. I wanted to almost like respond to what Sean was suggesting, and the sort of the holding the quantitative scoring as a foundation, offering an interview to get more information about things that we haven't adequately characterized there in the quantitative, but also the quantitative is very much dependent on how good a job we can do of anticipating what the important stuff is. And the better job we can do, the better job anticipating, projecting what are the important things, what do we know about the market and what the options might be, the better job that quantitative set of very highly developed questions can do of reflecting the quality of the applicants with regard to meeting our desires, but it can't do as good a job of assessing those innovations like you just mentioned, Sean. And I think that the interview process gives us one opportunity to get insight into that. And this scoring, giving ourselves a little flex at the end of the day, also allows us to acknowledge things that we can't anticipate that might show up during the process, that we want to value in a way that we didn't build in anticipation because it has come up during the process. So that's why I appreciated the 2.5% flex around the reality that the scores can only be as good as a couple of limiting factors, one of which is the proposing how good a job we can do of anticipating, and another being the variability between scorers and this kind of stuff. So I appreciate the combination of those three approaches to try to get at what is most important, including leaving us a layer of flex to be responsive to the process itself and what emerges during the process itself. And with that, I want to acknowledge that we have spent quite a deal of time in the first of the three sections for this part of the meeting, and wanted to see if we can streamline a little bit for this next part.
Definitely.
Emery.
Okay, definitely.
Emery,
Brian,
I would say, are there any concerns with this concept? That would probably be a good thing just to note right away is, do any board members have some overarching concerns or pause about this sort of structure?
The only concern that occurs to me is the acknowledgement of conflict of interest. And every time we give ourselves flex and provide cushion to the process and the scoring, then that's a place where things can potentially go sideways if there are conflicts of interest. That's what's allowed in those spaces. So just being very, very attentive to those things that could push us off the core of our commitments to our values as we have stated them here. That's the only concern I have.
And staff and Mercer have taken a lot of, I think, pains to make sure that these concepts as proposed do not bring with them, any overarching legal risk that would make them not advisable from DOJ standpoint. So Sean had mentioned the term guardrails earlier, and that's exactly what we are trying to build in here, is its flexibility, but within very specifically defined guardrails.
And I would say these are pretty conservative guardrails from what I've seen in selection processes. So yeah. Yep.
Yeah, definitely appreciate it. I think we'll there's a lot of feedback. We'll take a look at, listen to it and discuss. I don't know how much we might change it, but we'll definitely take a look at it and see what. I mean, we need to provide a little more detail around some of these guardrails, but we will definitely work on it and come up with the final version. Okay, so I think a lot of the questions were really kind of more about, scoring and weighting. Essentially, what are the elements of the RFP that we're going to be highlighting? And this next few slides we'll go through kind of quickly. Well, actually, maybe this one we can go through quickly. Right now I mentioned 75% on the written portion, 25% on the finalist interview. Maybe based on feedback, maybe the finalist interview might be a little bit higher to give a little bit more. I don't know if it's discretion, but really kind of weighting those questions and updates that the PEB board might want in this case, and in the medical and pharmacy 80/20 in this case. Okay, next slide. Okay, so I think on the medical portion of the questionnaire, this is what we have for the primary topics, and we have a slide for each of these different topics with like some sample questions we might be asking for the board to score. But essentially, the weighting there on the left is our first attempt to essentially kind of come up with the values associated with each of these elements. And then on the right, there are sub sections of each of these primary topics with like essentially weightings for how the points would be allocated based on the types of questions. So essentially, financials would be 25% there at the bottom. And then clinical services and member experience would be essentially 40%. Network access is 15%. And we have data and services each having essentially 10%. But I think maybe of more importance to the board members is kind of like these sub score topics as well within each section. So you can see that advocacy and navigation is a big portion of the member experience, so 60%. So if you take that 60 and the 15%, that gets you about 9% of the overall score will be for advocacy and navigation. But behavioral health, you can see essentially is the second column under member experience, but it's also in clinical services as well as network and access. So it's 20 the weightings we have here, these are kind of our draft weightings, but still a decent chunk of the member experience is based on behavioral health in terms of like maybe advocacy and just kind of like getting providers and getting members to the right providers and stuff like that. But clinical services, the integration and how behavioral health is integrated we have it at 40%, which is also right now same as physical health. Health equity, dealing with some of those other questions, making sure equitable care is 20%. So you kind of add up the primary score times the sub score to kind of see the overall value of each of these kind of sub elements. So behavioral health is, hopefully these numbers show we're going to make it a key part of the RFP. With the network and access to your question, Representative knows, trying to get that's 40% of the 15%. So, that's 6%. The overall RFP scoring right now is just on behavioral health network access. And then you add some of the clinical services and other things. So behavioral health, it's going to be close to a quarter, 20 to 25% of the overall weight, overall scores in this case. So we are trying to essentially, hopefully, meet what the PEB board is actually wanting in terms of the weighting and the importance of these things in the RFP. So with that, I think just wanted to see any thoughts, comments, initial reactions on what were the elements of the RFP and the types of subsections that are going to be in the RFP as well. See if there's any questions or comments. Yes, Emily.
This is really great work. I was just wondering with advocacy and then health equity. So I don't always separate out health equity. It's sort of, for me, it's like embedded in the advocacy. So, that advocacy needs to be culturally and linguistically appropriate. So, if you have a patient or client or, who doesn't speak English, right, then the advocacy may fall short if it's only in English. So just curious how, like within the advocacy and navigation, is there health equity?
Yes, and yeah, and I'm not. We do have a sample question, a couple slides, which I hope is kind of. It's not. I don't know if it's as directly on point, but hopefully it's kind of on point to the type of question you're asking. We do have other questions that are definitely tied to health equity, and I think, well, yeah, we'll definitely look and try to create that kind of thing. Health equity is going to be essentially. I mean, we do have this as kind of a breakout, but it's not really. A lot of the questions really will have hopefully a health equity component to it to kind of bring it all together, so it's like not just discrete, it is all tied together. And one of the things what we're thinking about doing is also creating essentially value statements for PEB in to start out for a lot of these sections to talk about, how important health equity is and how PEB wants, care to be equitable across, just the various elements. And it's like, it's going to be embedded in all of that. So hopefully that kind of will kind of meet the way that you're viewing this as well. Maggie.
Okay.
Yeah, thanks for your question, Emily. I think, as we talked about earlier in our RFP kickoff process, we wanted health equity to be throughout, right? Because that's really the foundation for PEB. And I think one of the reasons why we chose to illustrate it here, right, is to ensure that the board sees how much weight it has in each of these sections so that it's not just, a certain number of questions are in there and are important, but like, the first section, that's 3% of the total RFP score, and you just add it up as you go through, because we want to be meaningful about how much weight overall it has. And if the board feels that's not enough weight, we're happy to discuss, but we want to make sure that we're really thoughtful in each section about capturing those questions and answers and giving them a score as it relates to PEB's goals and Oregon's goals overall for health equity for all.
Okay, thank you. That's really helpful. Thank you.
Yeah, and when we were looking at like our typical template for like RFPs, we were going through this and we're like, health equity or diversity was kind of like its own small section, and we're like, this is not working for PEB. It has to be part of the overall. And so we're, as we're going through and writing the questions, it is going to be embedded, hopefully, and hopefully that will show as the questions are written. Okay, Chiki.
When you get a chance, it doesn't have to be today, would love to know more what the formula or how advocacy ROI, the last line, is calculated. Like, what does that look to us?
Yeah, so I think in terms of the financials, this is just kind of off the top of my head for right now. In terms of the financials, it's kind of like the guarantees around it, right? What have they proven that they've gotten? Have they have papers, or they can they demonstrate the actual returns for the clients that they currently have, right? What can they demonstrate, and what else are they going to guarantee? I think that's going to be part of it. It's like the requirements, like, yeah, are they going to if they're going to guarantee like a 3-to-1 versus a 2-to-1, and they're going to give like 50% versus or 75% of the admin fees back? Those sorts of types of questions is going to be part of that. This is really the financial. It's like how well will they demonstrate, or can they demonstrate that return and provide guarantees in case it doesn't happen for PEB, so that PEB isn't harmed. So those are the types of things I think we'll update. We'll get those questions nailed down, but just more financial aspects. Ruby, was there something?
Yeah, I just wanted to make sure that we get feedback from the board in terms of what our scoring methodology is, and making sure that we are on track, and if board members are comfortable with this scoring methodology. Okay, I guess we're good. Thank you.
Yeah. Okay. So next slide is going to be talking about the pharmacy. This is going to be scored by Mercer in terms of the types of things. So pricing is 25%, pricing requirements is another 10% in caveats. Then we have like essentially 12.5 for networks and network disruption, because that was a concern that was brought up during the retreat. Formulary disruption, if they change the formulary, how much disruption and what's the formulary look like? That's another 12.5%. And then we have some other performance guarantees, service and transparency is 15%. So this is essentially, again, our draft weighting for the pharmacy. I don't know if there's any initial reactions to this. If you need more time to think about it, that's fine. But this is our first pass in terms of the scoring proposal for pharmacy. And again, 20% of the overall score would be for pharmacy. Okay. So go ahead.
I don't know what my opinion is on this point yet, but I'm just noting it for the board, and I'm just kind of like open to that discussion, not necessarily at this minute, but disruption, the network disruption, potentially, I don't know, might be a bit high. I mean, it's like we're going out for bid, and it's like, yeah, there could be some disruption. I don't know. It happens, but it also, I know, like, we have a very large membership, and like so this kind of gets back to our point about like having communications out and being like, hey, the board's going out for bid, just so you know, and like we don't, that kind of thing, just kind of preparing. So anyway, I'm just bringing it up. I'm not against the 13% right now as it is, especially, yeah. So I'm just flagging it. That's all. For maybe future discussion. I don't know.
So Sean, this is Ruby. Just wanting to make sure, in terms of the disruption, both for network and also formulary disruption, you're thinking that 13% for both of those categories is too high, or are you thinking more one versus the other?
It might be too high for both.
Okay.
I'm saying
as
an initial thing, like that's just my initial reaction, and I'm not speaking for the whole board, obviously.
Yeah, so I would.
Right. So
this is Andrea. I'm opposite. I think that those work for me.
Yeah. So.
Okay. Well, we could go back and fine tune a little bit and see where we can meet in the middle to make sure that we that everybody's comfortable in terms of the pharmacy aspect of things. So that gives us good
I don't know if I have a position that it's too high, right? So I don't know if we need to like, I was bringing it up as a topic of like, shall we discuss it? That sort of thing. That's all.
Okay.
Well, honestly, one of the biggest challenges with this RFP is there's no right answer, right? This really is a balancing test. And so, Sean, I would expect you and other board members not to necessarily have the most specific feedback right now. So keep what you're doing, sharing your initial reaction, and again, what we'll bring back to you in the future, we'll take all that feedback into consideration.
Yeah, and so if there's a certain element here, that you feel like should be higher, potentially higher, in addition to lower, let us know. If we do make adjustments, we should get to 100%, and then so bouncing test in this case.
Hey, Emery and Brian, I
Yeah.
just wanted to double check on the earlier slide when we were talking about a little bit of flexibility on the plans. Disruption was part of that, but that was only network disruptions for medical, right? There wasn't anything in there around disruption on pharmacy. I'm not sure I remember for sure.
We didn't specify that. I think the intent was potentially medical only, or at least that was, I wasn't thinking about pharmacy. I mean, disruption, we can definitely consider pharmacy disruption. We haven't finalized what that disruption criteria is going to be exactly. So we can definitely take that into account if that's of importance.
Yeah, I mean, I just wanted to echo what Andy was saying. I do think that there's a risk with a lot of disruption. So it's just something I think the board should be paying attention to, whether that's medical disruption around the pharmacy or provider.
Okay. Noted. Okay. So definitely, oh, Ollie.
Sorry, go ahead and go on. I was just going to say that maybe you could talk, when with regard to the weighting, if these are kind of industry standard weights or we're weighting them a little bit more, like say disruption, this is weighted a little bit more in that direction, might help weigh the process.
Yeah, so on the pharmacy, I think we I don't know if Sarah's back on, but pharmacy, we definitely, I think it's both of these are heavily, we heavily took into account what we thought the PEB board wanted. So,
exactly.
I mean, while, a lot of this, in general, I don't know if there's a general industry weighting. It was kind of like, what do we think PEB really wants? Where has PEB been talking? Where have the pain points been? And we, based on that, we came up with these percentages. We a lot of feedback back and forth. I mean, I don't think it's really like industry standard. I mean, I think we kind of really try to make it PEB centric.
Got it. That's very helpful.
And if I may,
so hopefully, go ahead.
Sorry. And if I may express my biases as a clinician, for clinical capabilities of a health plan to be weighted at 10% seems potentially low. I want them to be able to deliver everything clinically, and maybe we're making a fundamental sort of presumption that they're all going to meet some base level of delivery of clinical capabilities, but that seems potentially low.
So for the medical portion of it, we go back to the prior slide. It's actually 25% for clinical services. This is pharmacy. So I think a lot of it, we would assume that would be medical, really, on the pharmacy, what drugs are prescribed, but there's going to be some pharmacy clinical needs.
Thanks for that reminder.
But yes, doctors are more important than 10%. Okay. So let's move on to the next section where we kind of talk about the various elements and some sample questions that we would anticipate the board scoring. So I know we've been discussing this for a while, so maybe, I don't know how long, I'm not going to prevent you from talking. But in terms of the draft section contents here on the left, so there's just some bullets on. It's nowhere near a complete list of the elements here, but we have a lot of different bullets to help describe what's going to be in there. But maybe more important, the sample questions for the board to score, we are kind of anticipating like essay type questions. I don't know, college essay questions. I don't know, just kind of really getting at what they are doing that and describing what they're doing and demonstrating what they're doing so that PEB board knows exactly what the plan brings to the table, right? So this first question, Emily, I don't know if it's not, I don't know if it ties exactly to health equity. It's, but it's it's one attempt to kind of bring in the member experience and health equity together in this case. Strategies to ensure equitable care in rural communities. And, please provide examples. We don't want to just have words. We want you to show us what you actually done to do things like this. And so that's a potential question. And then the second question is about the holistic, assisting members with the holistic. So this is navigating to various services, programs, additional benefits that are outside and demonstrating that need. So those are two of the sample types of questions we want the board to potentially score. There's going to be a lot of process questions that we aren't going to be asking the board to score. And so we didn't show them here, but there's going to be a lot more questions, but this is kind of like the samples for potentially, if you do want to be a board score, this would be the type of questions you would be reading and scoring. Andy, was there something you wanted to discuss?
Oh, I was just wondering for the if you're wanting an essay style answer for 250 words is pretty minimal on some of these. Anyway, just coming from a professor, that's my thoughts. That's it.
Yeah, no, it's the word max is definitely just, we're tossing them out there. I don't know, maybe it's we can definitely increase and change.
Yeah, I think the individual questions will tweak. I think for now, the most important thing is the substance of the questions and how you guys feel and how you react to them. Oh, and just another note too, we do want to have word limits, even if we tweak them, or else people are going to be scoring or sifting through a lot of marketing material and other extraneous information.
Yeah, so I think we have about 10, 15 minutes left in this presentation. I think we'll go through some of the other questions very, very quickly because we do need Ruby to kind of talk about and ask for assistance from the board to be participating. So the next slide's clinical services, and I'm going to take less than 10% of the time for this one, but just what's going to be in the section, and then a sample question here talking about opioid use is just one potential question there. Again, another essay question, potentially more than 500 words, but something to consider. And we have a lot of these questions that we've drafted, just trying to create ones that the board might be interested in, I think. Network and access. So talking about the diversity of providers, centers of excellence, size of the network, and disruption, the medical home networks. And then talking, there on the right, some of the questions, race, ethnicity, very important. Network strategies, addressing shortages. So those are potential questions we'd want the board to score in this case. Okay. Next slide, data and reporting. So some of the elements there on what we're asking for, getting more stratification, more reporting, better member engagement. And then some of the questions, like how do you use data? How have you used that to improve, identify disparities and change how healthcare is practiced? So those are potential questions on the right. Okay, next slide. Services administration. So this one's probably more going to be staff and Mercer scoring. We do have a sample question there talking about how you have worked with large, complex organizations, especially like PEB, to make sure that everything is running smoothly in this case. And then the next slide, talking about financials. Administration and other performance guarantees in this case, those are big portions of it. And then I think maybe, in terms of the question we ask every year, how do you work to a 3.4% limitation, but really kind of like the strategies that the plans would be using to make sure health members are healthier and the costs don't increase very much. So those are some of the sample questions we might be asking. And if, those questions, actually interest you and you want to actually read them and understand, score them, then this next section is for you, which is talking about RFP roles and with participation by the board. And with that, I think I'll turn it over to Ruby.
Hello, board members. My name is Ruby Castaneda, and I am the PEB staff person that is leading the RFP. If you could go to the next slide, please. So this next slide is a refresher from the retreat, and it just talks about who on staff and who on Mercer is helping with the RFP and the process. And then it goes into what some of the other aspects of the RFP is, such as the work group and the evaluation, and then also finalist interviews and whatnot. So if we go to the next slide. This is also a refresher from the retreat where we pose the question of, hey, board members, these are the various options that the board can take in terms of evaluation and scoring as well as finalist interviews. And so the first option was option 1, where we have 5 to 8 board members. If we have a full board, then all the information will be public meetings, and we will have full participation for the board. That means that everybody within the board will score and evaluate and comment on the selections or proposers. And then option 2, we have fewer than 5 members. Most of the meetings will be in private, and we'll just have some board participation as well as staff participation. Option 3 would be that board members would only be scoring the finalist meetings, and the staff and consultants will be scoring and evaluating all of the written proposals. And then the last option was option 4, where we won't have any board participation for the written and the scoring, and we'll be looking more to the staff and Mercer in terms of our recommendation for the selected proposers or the finalist proposals. So we start option 2. I think that is, we would want some board participation. And we did ask at the retreat to consider whether you want to be a work group member or an evaluator. And then if you go to the next slide, this may paint a clearer picture in terms of hours from a evaluation perspective versus a work group perspective. So these are my best guesstimates based off of previous RFPs. But I just wanted to give the board something in terms of how much time commitment there's going to be in terms of this. So option 1 is the highest option, which it has the most questions, and it will be more time consuming, and so there will be a big lift for board members. Option 2 is 50 questions. And given that we're going to have scoring and evaluation be within a 4-week period, we anticipate it to take 4 to 5 hours per day for you guys for any board member to evaluate and score. Option 3 would be 30 questions. and it would be 3 to 4 hours per day. And then option 4 would be 10 to 15 questions. We were thinking somewhere between option 3 was going to be a recommendation, but it's also up to what the board feels comfortable with. So this is only for written proposals. This does not include the finalist interviews because that is hard to determine because we don't know how many people are going to propose and we don't know how many people will be within that 2.5% in terms of finalist interviews. So I did not even bother to take a guess at that. In terms of a work group hours, I still anticipate it to be, 8 to 10 hours. And even though the meeting invitations may be for an hour long, it may be that we only need a board member there for like the first 30 minutes or so. So yeah, that's all what I have. Didn't take 15 minutes, so mine was short and sweet. But I do want to get some feedback in terms of what the board is comfortable with and hopefully recruit some people.
And Ruby,
So
Chiki had a question. She said,
Oh.
I'm sorry if I missed this. Which months will the 4-week period be in?
Oh, good question. I
Yeah.
think we were looking at September. I think is when we were looking. I'd have to look back at the timeline. I don't think we have the timeline up. Sorry.
No, and just a note too, the timeline we've developed is very preliminary because part of
Yes.
what we need is to get your guys' reaction to all this high level structure and process stuff. And based on that feedback, now that we've received that feedback, we'll not only be drilling down into some of the details that you expressed interest in, but we're going to be stepping back and revisiting all the timeline. So all that is to say, I think what we have developed and what we've shared previously may change based on the discussions of where we're at today. And sorry
So
for that
this is
non-answer.
Shabbat.
go ahead,
I just
Siobhan.
wanted to, I just wanted to jump in. So I know we had, we're leaning toward option 3 when we had the discussion at the retreat. I know we talked about a September, October timeframe initially for those interviews. I'm still comfortable with option 3, and I just wanted to express interest in being part of the work group, which I understand would be scheduled over the next many months leading up to September.
Yes. So if you're going to be part of the work group, the plan is to have the RP released maybe in April sometime. So so the work would be essentially from now, probably, well, maybe after winter break, but January until essentially
and Emery, that's still part of the
Okay.
timeline, I think, based
Yeah.
on what we're hearing. We're gonna
Need to
have to go
reevaluate.
back. So
Yeah.
Mhm.
But
Yeah.
I'm just saying, like the rough one that we had initially, it'd be in the next few months, and then so late summer, like in terms of the board consideration for evaluating and scoring in this case.
Okay.
Sean.
So
Oh, sorry.
So just for my clarity here, how many work group PEB, board members are you looking for? And how many, I also am thinking about option 3 and support that. So under that scheme, if other board members agree on that, I don't know, we need to vote or whatever, but how many board members would need to be doing that?
So in terms of the work group, I just need 1 or 2 board members. That would be ideal. In terms of the actual evaluation, we're looking at, if you go to the previous slide, please. We're looking at fewer than 5 members for the evaluation part.
All right. And is my understanding right that the preference is that if you're on the work group, that you are not one of the scorers then? Is that the situation?
That is.
Okay. All right. So, yep. Option 3 makes sense to me. And then I'm happy to be either a reviewer or a work group person. I'll kind of leave it to the staff and the chairs about like what's best or what's the preference there, but I'm open to either one.
And
Greg.
Hello.
Hi.
This is Greg. On the phone, of course, and still driving. But I agree with the 2 to 3. 3 is fine. And as well, I would definitely serve on either of those, be it as Scott said, a full board or whoever. I definitely would serve on either to get through this process. Have it done in a good time. So thank you.
Okay.
Thanks, Greg. Andy, I think you had your hand up next.
Yeah, so same with the option, and probably would be easier to do work group if we're gonna do scoring in September, just because that's probably the busiest month I have all year. But I'm happy to be an evaluator instead. I can make it work if we can get that timeline a little closer to done, so I can make sure that I can get the time from my duties. So yeah, but just let me know either way whenever you can.
Andy, were you saying option 2 or option 3 would be okay for you?
Yeah, or I think we going number 3 now? Yeah, 3 is fine.
Option 3 for written proposals.
So if we go with option 3, we are not scoring all of the applications at all. Am I correct?
Oh.
No board member
No.
sees all of the applications.
I think that was for, I think what the option 3 is the amount of questions for the written proposals. Is that my understanding?
Oh, I guess
Yeah,
I'm confused.
So you would be reading all of the RFPs, but the number of questions in each RFP that you'd be reading and scoring would be about 30.
30.
So, in terms of the various sections we have up above, I think we have 6 maybe sections. You would essentially be having maybe on average 5 in each section, probably more, based on the weightings, but more for the clinical.
Right, well, I'm good with
and
2 or
member
3.
experience. Yeah.
Okay.
Yeah, 2 or 3.
So there's 4 options on slide 24 and then 4 separate options on slide 25. Those don't correspond to each other. Yeah.
Yeah.
And just to clarify, what we've done in the past and what I envision us doing going forward is we will make the full proposals available to all evaluators.
Mm-hmm.
I don't think the board, for you board members, you're not expected to necessarily read all of the proposals front to back. We do provide them because there will be some related answers that you may want to, browse just in terms of context. But as large as these things are, we would not expect you to do a front to back reading of all the proposals because that's a lot of information.
Vicky?
Can you please go back one slide to slide 24? So option 3, when we say staff and consultants score proposals, are we just talking about PEB staff, or are we opening it up to other, member enrollees / enrollee staff members so that we can open it up to the quote unquote community, if you will?
So we were thinking PEB staff. Many PEB staff are also PEB members as well, and we would and also consultants as well. So it would be the board would not review or look at or score actually the written proposals. They would just be scoring the finalist interviews. It would be option 3 in terms of the evaluation and decision. Option 2 would be members of the board are scoring and evaluating proposals along with staff and Mercer.
Yeah, and we have not contemplated having any external folks, including PEB members, actually score and evaluate proposals. I think what we do have another kind of parallel conversation going on, and I believe a meeting scheduled this Friday, to talk about how we may want to reach out to get more member feedback to help inform some of these portions of the RFP before it's released. But that's different. We had not contemplated actually assigning out evaluation and scoring for any outside members. I think one exception could be there may be technical areas in the RFP where we reach out to certain technical experts in OHA. For example, maybe someone in health equity if we feel we need to get another evaluator for those specific questions, but those are going to be very limited and very kind of expertise or subject matter expertise based.
So I mentioned that, right, in the vein and in the theme of, is there an opportunity to do the whole power sharing, provide our outside members an opportunity to feel like they are part of the process. And maybe they don't have to score the proposals. Maybe we ask them as advisors. Your point, Brian, of maybe certain sections, we ask them for their feedback. And that could be a resource also for the formal scorers and even the board members that we've consulted our outside members. So just some things to consider. I would strongly advocate for if we can involve outside members somehow, some way, even as an advisory capacity, so that we can also practice what we preach about power sharing. I think that would be fantastic.
Okay, definitely. Don, did you want it? Or did, I'll go to Sean. Sean?
Yeah, so just to clarify, I realized I didn't clarify when I was speaking. There's two sets of 4 options. You know what I'm saying? So on page 24, I think we're looking at option 2, which is that there is some board review with staff. Okay, so I support that. So I don't need, for myself, I don't need to see that slide at this point, because I feel like that's maybe what we're doing. So I see some thumbs up and such. On slide 20, go ahead.
Sean, may I take that over the
Please.
line? Are there
Yeah.
any board members
Oh, yeah,
who
great.
are looking at slide 24, which is the one being shared with the star on option 2, that teal color in the upper right? Are there any board members who take issue with the recommendation of option 2? I do not. I support option 2. I heard that from Sean. I think I saw thumbs ups from Andy and Greg. Cheeky, option 2 on.
Option 2 or option 3, yes.
And Siobhan. All right. Could I just ask? Go ahead, Emery.
Yeah, I was going to say Siobhan did write in the chat that she liked option 2.
Okay. Did I miss anybody, or do we need to do a quick, drop it in the chat?
Yeah, and I was just going to clarify too, we don't need to ask for formal approval today, but to the extent we want to get straw polls, that's perfectly good.
Yeah, straw poll. What I think I'm hearing is coalescing around the recommendation of option 2 for evaluator options and decisions on page 24. And I see a couple of thumbs going up, but my screen is not telling me whose they are. Okay, in which case, thank you very much, Sean, for that clarification. Let's go to option slide. Anyone who has issues with that, please drop. I see an option 2 there. Okay, please drop any concerns in the chat or speak up. And now we can move to slide 25. And I've heard 2s and 3s here. And okay, Sean, back to you.
Yeah, so on this slide, I mean, I'll make option 2 work, I'm comfortable with option 3. And the way I understand option 3 is that PEB staff and Mercer, someone is evaluating all of the questions, and there will be many more questions than 30. But what we're doing is we're selecting 30, and I would suspect that the board would have influence on which 30. We're selecting 30 questions or thereabouts that this subset of board members are actually scoring consistently across all of the proposals. probably stuff around, health equity, behavioral health, and a bunch of things that come up every meeting. So there's like that. So then staff and Mercer would be reviewing and scoring other questions. And then the board has this, these particular 30 that they're really scoring, and then you kind of combine them together and be like, here's this thing. So that's the way I'm understanding option 3. And as opposed to option 2, which is kind of like in between option 1 and 3, which is like kind of same idea, same point, but there's just more. 50 questions out of the 75 or whatever total. So I don't know. I'm 60 to 80 hours over 3 to 4 hours a day for 4 weeks seems pretty solid as far as due diligence from the board, I'd say, my personal opinion. So that's my thinking.
And,
for what it's worth.
Sean, I think I'd also point out, Ruby included a bullet on this slide under notes, the third bullet, that with the finalist interviews being worth a quarter of the overall score, we do envision assigning the board member evaluators a large portion or proportion of that scoring for the finalist interviews. So you guys could look at options 3 and 4, and still your weight into the final decision is going to be pretty substantial. Does that make sense?
Yep, makes sense.
Okay.
Appreciate you pointing that out. Yes, this is not even including the interviews, right? In other words, so which the whole board will do.
Yeah, and there's so much in the underlying, just the original proposals before we get to finalist interviews that will be evaluated based on just technical information and some other objective analyses that, it's just, there's a smaller percentage of stuff that would be appropriate, not only for board, but just general staff evaluators than there would be in the finalist interviews, which are more, again, I think higher level and not so much focused on some of the technical details.
Thank you. Does anyone else on the board have the capacity to speak to your interest in participating either as a work group member or as an evaluator? I heard from Sean either. I heard from Siobhan, work group, Greg, work group or evaluator. Andy, work group would be easier if September, but maybe both. Chicky and Emily, I don't think I heard those things from you. If you are able to speak to them at this time, and if not, then not.
Yeah, this is Emily. I was actually happy to do both, but it sounds like we have to pick, right? One or the other. We can't participate in both. So then, yeah, maybe with some clarification of timeline, but I'm leaning towards the evaluator then.
And some of us won't have as much time to be able to participate and won't be able to be evaluators, myself included. And so the work group would be the only opportunity that I might be able to participate. So if you are able, evaluator option would be welcome, but you're also welcome to say either would work. Let's see what the whole constellation looks like, and we can work through that conversation.
Yeah, and the process doesn't require every board to participate either as a work
Yeah.
group member or evaluator. In fact, for public meetings issues, it's easier to limit the number of evaluators to, again, 4 or less. So I don't want board members to feel like they need to participate in one of those roles, because unless you have a conflict of interest, you'll still be part of the discussion and voting on selecting the finalists and ultimately the winners.
Thanks for that reminder, Brian and Ruby. Cheeky.
Dawn and everybody, if I can be high maintenance this year, 2025, my role will be in flux, as well as it's just going to be a crazy 2025 for me. So would it be possible, like I'd like to feel special and be invited and then the right to say no if depending on the month. So like September, October, that's going to be really rough for me because marketplace open enrollment starts November. So, but again, every open enrollment is also different. And we have a new federal administration next year, so I don't know how hectic it's going to be. So if I can just be high maintenance in 2025 and I just be invited to everything, and with the right to maybe wave the white flag, I'd love to be high maintenance if that's okay.
I'm actually totally happy to take requests at this time. I don't think we're making any final decisions about roles or whatever, but it is certainly helpful for us to understand, and we can have a little of this conversation now and conduct more asynchronously by email after the fact, after you have a chance to sit with the information, take it back to your supervisors, whatever it is, and we'll come to some recommendations about what a fit might look like for everybody's opportunities to participate. How's that sound? Thumbs up. Okay. All right. I think that we just saw sort of a straw poll settling in on option 3 probably for this as a possible solution, and we have enough people, everybody wanting to participate as they are able, which is wonderful. Thanks, everybody. We'll figure out what that's going to look like. Mercer and staff, is there anything more that you need from this conversation right now, or more directions you want to take it? I'm happy to turn it back over to you.
I don't have anything in addition. Thank you.
No, but yeah, but definitely thank you for the great discussion and the views. I mean, that's going to just help shape everything. Emily.
Yeah, and sorry, I just want to squeeze one last comment in because that slide where you were giving a draft sample question and calling out holistic care, that just reminded me of previous conversations we had about like alternative health and healing and naturopathic remedies, and just some that are more aligned with culturally specific communities in Oregon. And I have since learned that Oregon and Washington are the only 2 states in the country where naturopaths, people can choose naturopaths as their primary care doc. And so I just wanted to make sure that we're still being inclusive of those types of approaches.
Yeah, well, we'll definitely take that and note that and take that into consideration as we're writing down. I mean, there's going to be a lot of making sure that the next bidder, the winners are matching what PEB is currently getting. So a lot of those elements will have to be, agreed to, and we'll just be sure to note the naturopaths and alternative care.
Okay, thanks.
Thank you, Emery. I'm noting that we were supposed to have a break a few minutes ago and that we didn't pause for that. Perhaps we could take a short break now. Can we make it happen if we take 10 minutes, or do we need to keep it to 5 right now? Can we take 10 minutes? Mercer, you think you can swing it? Trend rate guarantee.
That's actually going to be Margaret.
Margaret,
that.
Margaret.
We may be helping her out on that one, but.
Yeah, and Dawn, I'm estimating we need about 10 minutes for that one, but I think we have a little more allocated if needed.
Okay. Given all the givens, 10 minutes for that. All right, let's go ahead and come back for an 11:40 start return here, okay? So that's 7 minutes. I'll just put it in the chat. Everybody, if you would, please take a break, stand up, stretch, go get yourself something to refresh yourself, and we'll see you back at 11:40. Thank you. Good morning, all. Welcome back. Board members, when you are here, please go ahead and come on camera or let me know that you have returned. Hi, Margaret. Hi, Chicky. Emily. That was a short break. I see you, Rub Nose. Thank you. Boy, this little laptop screen is not letting me see everybody.
That's
This is
also a
Greg.
thing
I'm
in
here.
Teams.
I'm
Teams
here.
doesn't do a great job of letting you see everybody.
Hi, Kimberly. I see you. Greg.
It's Siobhan here too.
Hi, Siobhan.
Andy's here.
Thanks, Andy. Did I hear Sean? And I think we'll go ahead and given the time pressure, we'll trust Sean to catch up when he returns.
I'm here.
Oh, hey, Sean. Welcome back.
Hi.
Margaret, the floor is yours.
Great. Thanks, everyone. Good morning. It's good to be with you. I have a brief report out for the board this morning on the results of PEBB's medical plan trend guarantee. This is from the 2023 contract year. And we are going to specifically ask for the board to make a decision around how you'd like to approach settlement for this guarantee. Next slide, please. So just to kind of provide a refresher in terms of the background, PEBB medical contracts include performance guarantees for our carriers. All of the contracts require that each carrier places 15% of the administrative fee component of the premium at risk for annual performance measures. And in the 2023 contract, those measures were across 3 different areas. 5% of those fees at risk were for administrative performance measures, 5% for clinical performance measures, those being HEDIS measures, and then 5% for the cost trend guarantee. Note the asterisk, you may recall, at the very early portion of 2024, the board made the decision to go ahead and move the 5% of administrative fees that are at risk for plan administrative measures to shift those to behavioral health network access measures in the 2025 contracts. So that switch will be taking effect with the start of the new plan year in a couple weeks. Next slide. And so today, specifically looking at the results of that cost trend guarantee. Again, recall the guarantee requires that each carrier maintain a sustainable rate of annual planned cost growth. It is in line with the 3.4% annual cost growth limit that PEBB must comply with per statute. And under the contract requirement, carriers owe a penalty to PEBB if the guarantee is missed. And you'll see listed on the slide sort of how that penalty shakes out. So if the year-over-year cost growth is 3.4% or less, there's no penalty. If it falls between 3.4% and 4%, there is a 2.5% of plan year administrative fees for the penalty, and 4% or greater cost growth is the full 5% penalty. Next slide. And so in terms of the results for the 2023 plan year, all 3 carriers experienced annual PEBB plan cost growth that exceeded the 4%. You can see on the slide the observed rate of cost growth for each plan, all of those being subject to the full 5% of the administrative fees penalty. So it shows the penalty amount due by plan. Again, that penalty amount is based on total administrative fees paid to the plan for the plan year. with the total amount of penalty dollars due coming in just under $2.5 million. Next slide. And so here's where we're hoping for your decision today. In terms of settlement options, there are a couple ways the board could decide to go. These may sound familiar, as I believe this same discussion was had last year. One option is to have the fees remitted as a direct payment to PEB reserves. This is easy to administer. A consideration is that reserves can be appropriated to address state budgetary needs, as has happened in the past. Another option that we've identified is that the board could use these penalty dollars to specifically earmark them to fund improved benefits of some sort. This could align with PEB goals around improving member health status and the goal of kind of improving long-term health. A downside is that this is a single year penalty dollar, so it's kind of one-time funds. It doesn't necessarily provide the sustainability for, say, like a new program addition in the long term. And may also, depending on how this is pursued, may require a limitation increase and potentially a separate fund if these were to be designated for an express purposes rather than just, PEB's general reserve fund. The option we are recommending, and the one that the board elected to enact last year, is that the penalty dollars be used as an offset to the renewal rates for 2026. So this would be, it would drive the goal of helping the board achieve the 3.4% cost growth cap to avoid, benefit reductions should they be needed, depending on where renewal rates come in or benefit changes. And in terms of how this works for a fully insured plan like Kaiser, it would be a direct reduction to the final renewal rate, credit to the renewal rate provided by the carrier. For MODA and Providence, which are self-insured plans, the board could apply this as a rate buy down essentially to the final premium rate. In terms of cons to this approach, we really haven't identified downsides. I know in the past there have been questions about does the existence of the penalty and the requirement to provide that influence where renewal offers come in at baseline? And I do believe, in discussion with Mercer and our actuaries that there's pretty careful review done of the renewal proposals and the plan experience to ensure that renewal offers remain competitive in consideration of penalties. Next slide. Oh, Sean, go ahead. I see a hand.
I will wait, and because you might answer it, so I'll just put myself in the queue,
Okay, great. Well, I do think the next slide is just requesting board action regarding preferred approach to settlement. So this is probably a great time for your question.
So I have a couple technical questions from the previous slide, just from my understanding. In option 3, is the idea that we would hold the money until next year? Like, I mean, not to be overly literal, but like kind of in our possession. Probably it would go into the stabilization fund or something, waiting with an earmark essentially to the purposes of buying down if needed. Is that the idea for MODA and Providence? Is that how it would work?
For MODA and Providence, I believe, and I will count on Emery to chime in here in terms of how this is applied to the final composite rate. But I believe that yes, like technically the funds go into reserves to be available to pay claims, but that when we do the final composite rate calculation, that dollar amount is factored in. And I see Emery nodding. So Emery, if there's technical nuance you want to chime in with, please do.
So the dollars would essentially, believe they would go into the fund, but essentially you would be using that as an explicit buy down on the self-insured rates.
So
Go ahead.
So the only difference between number 1 and number 3 is that in number 3, we're kind of deliberately earmarking it ahead of time.
Yes.
Okay.
Yes.
And to note in number 3 for Kaiser, it works differently in that it's a direct.
That was my next question. So how would that work with Kaiser then, I guess, in that case?
So in last year's, Ali, I'll just do this first and then I'll go. Okay, so in last year's renewal, when they provided their renewal, it was, they had their underwriting, they did their premium calculation, and they did have an explicit in the final premiums, an adjustment, a reduction to the overall cost as a result of this PG. So we got all of the other information. We took a look, and they have their standard process for pricing and stuff like that. We took a look at the claims, everything else, and so that there was like a status quo, and then there was a reduction for the trend guarantee that was then baked into the overall premium. So essentially, what PEB is paying out for each of the members is a little bit lower as a result. So it's, as Margaret mentioned, it is a direct reduction to the actual premium that PEB gets charged. Does that help? Okay. If you have another question, feel free to ask. Ali, did you want to mention something? Or
yeah, thanks. I just wanted to add a little color to number 1 in the con that reserves can be appropriated to address state budgetary needs. That came in the form of a $90 million transfer out of PEB reserves last session. So I think that that's becoming a more common occurrence. So I just want to put a dollar figure along with that con there. That's it. Thanks.
I appreciate that. I do have one last technical question, Emery. Like, Ali's point basically overrides my point, but I'm still curious about it anyway. And I don't think I've ever asked you this. In my mind, our reserves, it's like literally a bank account. I don't know if that's like kind of a childish way to look at it, but it's literally an account. But I assume that account generates interest, you know?
it does, Ali. Yes, it is a literal account. I mean, there's funds there, and there is interest, but I believe the interest is not very big because there's limitations in how you can invest there, right, Ali?
Yeah, there's really only interest earnings based on the state treasury interest rate, which is better than it used to be, but still pretty low. We don't have authority to make investments or anything like that out of this account. It just sits in treasury.
Okay. That was my last one. Thanks.
Thank you. Do I have any more questions or a motion?
I have a motion. This is Siobhan. I make a motion that we do option 3, offset 2026 renewal rates around the performance guarantees.
Help me out, Ali. There's a question. There's a hand up. Can I go ahead?
It looks like Chicky.
Chicky, yeah.
So technical question or silly question, however you want to categorize it. How does the performance in 2023, will it be a factor in the upcoming RFP if these same vendors apply? So just wanted for that for context for myself as we also enter into this RFP phase of how will this impact, or should it not, or it won't at all?
I'd have to rely on Brian Ruby on maybe the RFPs based on the RFP written portion of it, and that's what you're scoring and responding to. I don't know. to me, it's kind of like the butterfly effect. Yeah, it's like it's the history, right? And so the history informs the RFP, and then we ask questions on the RFP, try to be based on what's happening with PEB and how we're trying to improve it. In terms of the most direct thing is, I think, these trend guarantees and other performance guarantees and ways to meet the 3.4%. I mean, they're going to be big questions. They're going to be big requirements. And so maybe I don't know if that's the best way of kind of having it apply, but the performance guarantees and the financial guarantees that we showed the prior presentation, it's being influenced by what has happened in the past for PEB. And so we'll definitely incorporate that.
Yeah. And correct me if I'm wrong, Emery, but generally we're going to have to use kind of the latest current year kind of as a baseline for some of the financial evaluations, right? Because we have to determine
Yes.
what is the anchor point for that 3.4%. That said, that's different than what we will not be doing is assessing any of the proposers who are actually incumbents and current contractors. They're not going to get any additional points or subtracted points based on what they're doing today. It will be both based on what they propose going forward in the RFP.
So does that kind of answer the type question you're asking, Chiki?
It does. And I'm sure my brain is processing other questions. I just can't verbalize it right now, but I'll definitely keep an eye out for it as we go through work group sessions and then also the evaluation. But this is really helpful. So Dawn, sorry to derail for a second. I also support option 3.
All right. I see, Sean, that your hand is up. Can it wait until after the motion, or is it about this? It can wait? Okay, we'll do that. Let's go back and start over with motions. Do I have a motion, please?
This is Siobhan. I make a motion that we offset the 2026 renewal rates with the performance guarantee.
And this is Kimberly. I second that motion.
Thank you. Greg, how do you vote, please?
I vote yes.
Thank you. Chiki?
I vote yes.
Thank you. Kimberly seconded. Sean, how do you vote?
Yes.
Thank you. Emily?
I vote yes.
Thank you. The motion passes, and we will plan to offset the 2026 renewal rates with those funds. Thank you to Mercer for setting up a clear question for us to vote on and providing us with the information we need. Sean, is now the time for your question, or are we moving on to dental carrier updates? Our time is running a little tight. Please advise.
We can move on.
Thank you. All right, our dental carriers are with us this morning, almost afternoon. I apologize for the shortness of the time you were each given, 15 minutes. We have 30 minutes left. If your presentations can be tight, that would be appreciated. Otherwise, please take the time you need. Thank you for being with us. This is Delta Dental's update. Do we have Dr. Terry Barcello?
Yep, I'm here. Thank you very much.
Thank you.
And I'll go ahead and take over. I want to apologize right off the bat. I'm having really bad video issues with my laptop. I'm going to stay on camera as long as I can. If there's a stall out, I will need to drop off. I apologize. And I also want to introduce myself for those of you I have not yet met. My name is Terry Barrichello. I'm the Vice President and Chief Dental Officer for Delta Dental and MODA. I've been with the company for 13 years and am always love working with our government programs. And if you would go ahead and advance the slide for me. So I'm really happy to be here today to talk about some of the innovative programs and initiatives that we've been working on. And you can see from the topics on my agenda that generally we have been really focused on access and equity for underserved populations and medical dental integration. And as I go through my presentation, you'll also see that we really work to leverage strategic partnerships that we have in several of these endeavors. Go ahead and advance the slide, and one more, please. Thank you. So let's kick it off with teledentistry. Despite increasing patient acceptance, and I'm talking like general on the medical side and behavioral health side, for mobile and telehealth options, as evidenced by the stats you can see on the slide. Dentistry can be sometimes slow to adopt new concepts. Teledentistry has been around for many years, but has not yet been put widely to use. The pandemic created an opportunity to change the way we all view it and accelerate its use. And given advances in technology, the modalities for interacting with patients remotely and securely have greatly expanded in the last few years. Teledentistry can happen in one of two ways. There's synchronously, which is a real-time interaction like we're doing right now using phone or video conferencing, or asynchronously, where clinical patient data like photographs, radiographs, perio charting, it can be collected at a location away from a traditional dental home setting, and then this information can be reviewed at a later time by a licensed dentist. And I'm happy to say there's increasing evidence and growing acceptance by the dental profession. And I put myself in that category because I was an early skeptic of the accuracy and validity of the remote interactions. And in fact, recent studies have shown that even dental students using teledentistry were able to detect healthy structures with a 99% accuracy and dental caries or cavities with a 74% accuracy using digital photos taken by a patient. So not even off-site with a dental hygienist with an intraoral camera with high pixelation. There are a myriad of ways that teledentistry programs can be designed and deployed. So I'd like to show you how we're approaching it at Delta. Go ahead and move on to the next slide. So we have prioritized certain solutions and benefits for our members, and this includes 24/7 access to care regardless of location. We would like both synchronous and asynchronous options for screening, triage, and advice. And we want to make sure that it is very easy for members to utilize. We are looking to include a community care-based approach that could offer preventive services away from the traditional home. And we want to ensure members are subsequently connected to in-network providers for restorative and surgical care when needed. And we're doing this through two pathways. The first is a community-based approach where patients would receive preventive and early intervention services in community settings. That could be schools, that could be nursing homes, et cetera. Our hygienists and assistants are in the field, and technology links them to dentists and traditional clinics. And I am going to talk about that program in a couple slides. Second, we are working to finalize an agreement with a teledentistry vendor, and through their platform, which is secure, members can schedule video and phone appointments with licensed dentists across the U.S. They're in every single state around the clock, which will be a tremendous increase for access, especially in urgent situations. So let's go ahead and go on. You can go 2 slides for me if you would. Perfect, right there. And before I get into the details of our school-based sealant program, let me first explain who AeroDental is. That's the logo on the top right. So in addition to our commercial Delta Dental business, for anyone that's not aware, we also administer the dental Medicaid benefit for over 340,000 Oregonians that are covered by the Oregon Health Plan. So to ensure access to care, we have grown our operations to include dental clinics under the brand AeroDental. We've increased our footprint over time, and we now have 9 clinic locations across the state focused on serving the Medicaid population. And beginning last year, Aero has expanded to also include community programs. And that team includes 4 expanded practice dental hygienists, 2 assistants, and an administrative coordinator. They're currently serving 23 schools in Baker and Harney counties, and 27 schools in Columbia and Clatsop counties. And they provide assessments, fluoride treatments, education, and then they also work to coordinate referrals for definitive care when that's appropriate. The program thus far has been focused on meeting the needs of children in rural locations, but our intent is to grow over time. We're learning, we're growing. In addition to seeing kids at schools, preventive services and care coordination are offered 1 day per month to WIC clients at the Baker County Health Department. And this is our newest effort. We only began this this last June. Go ahead and go to the next slide. One of our very valuable partners has been OHSU. We have a couple initiatives underway with them. We kicked off a medical dental integration project last year aimed at providing basic oral health services on site at a pediatric primary care clinic. This is also accomplished through our aerodental clinics and their staff. We have an EPDH, it's an expanded practice dental hygienist, on site at Hillsborough Pediatric Medical Clinic 1 day per week, and offering the same types of preventive services that I talked about with the schools on the previous slide. And in this program, a large effort is made to help parents navigate getting connected with a dental home for their children. And a lot of them are Medicaid, but not all. So we're looking to connect them regardless of what coverage or not coverage that they have. Go ahead and go on to the next slide. I'm excited to talk about our newest medical dental integration effort that's under development, and we're partnering again with OHSU to conduct a diabetes screening study with our Aero patients. So I think with this group, I have talked about the correlation, or you may be aware of the correlation between diabetes and oral health, but as a very quick overview, it is a bidirectional relationship, meaning diabetes impacts periodontal disease and vice versa. So diabetes lowers the body's resistance to infection, making diabetics more susceptible to developing periodontitis or gum disease. Studies have shown that for every 1% increase in hemoglobin A1C levels, the odds of periodontitis increase by 18%. For diabetics who develop gum disease, the progression can be aggressive with more severe impacts, which can lead to tooth loss. Conversely, studies show that for adult diabetics with gum disease, if they get periodontal therapy and regular maintenance and regular dental care, they can improve their glycemic control and lower their A1C levels. According to the American Diabetes Association, in 2021, over 38 million Americans, which is over 11% of the population, had diabetes. And of that, 8.7 million didn't know and they had not been yet diagnosed. It's also estimated that over 97 million people have prediabetes, and alarmingly, 81% of them don't know they have it. So there's an urgent need for helping these people get connected to care. According to the AHRQ, in 2019, 28 million Americans reported visiting only a dental provider in the past year, meaning there was no interaction on the physical health side. So you can see this is an area rich in opportunity to make a positive impact both on oral health and overall health. Go ahead and go to the next slide. So we are partnering with OHSU Harold Schnitzer Diabetes Health Center to launch a program at one of our aerodental locations to demonstrate the vital role that the dental profession can play in screening for chronic conditions. So our clinicians will provide A1C screening, and as appropriate, will refer the patient to primary care for diagnosis and treatment. We will also be capturing certain clinical and patient data that the team at the Diabetes Center will analyze with the goal to publish results. And assuming, we're successful in this, the intent is to replicate this further in other clinics. Go ahead and go to the next slide. And I'm going to wrap up my time with an overview of the Tooth Taxi program. So the Tooth Taxi is a Dental Foundation of Oregon program, or DFO, and the DFO is the charitable arm of the Oregon Dental Association. The Tooth Taxi is a state-of-the-art mobile dental clinic that travels around Oregon and has been providing free care at schools to uninsured and underinsured children since the fall of 2008. And it began as a result of an innovative partnership between the foundation, OEA Choice Trust, and then it was ODS, now Moda/Delta Dental. I had to throw the old school logo up there for you guys. And each of the partners at the time recognized the devastating impact dental disease can have on children. At the time, it was estimated that 5,000 children suffered through their school day in dental pain. And dental disease remains more prevalent than asthma in children. Anyone who's ever had a toothache knows that it is uniquely miserable. It's hard to sleep, it's hard to eat, and it's certainly impossible to concentrate on learning. A study out of California found that students with toothaches were nearly 4 times more likely to have a lower GPA than those with no toothaches. Further, young children often struggle to communicate about dental pain, so it manifests as restlessness or hyperactivity behavioral issues. And as you can imagine, this is really disruptive in a classroom. So the founding partners were committed to helping address this situation. In addition to financial support, they've been essential to the lasting success of the program. OEA Choice Trust opened pathways for scheduling and communicating with schools. Awareness and trust in the program has been built as a result. And Moda and Delta Dental has provided ongoing funding, and we do the oversight of all the daily clinic operations. And that's something that I'm responsible for and is one of the most gratifying parts of my role here. And the picture that you see there, that's just a picture during one of the clinic days on site at a school. You can go ahead and go to the next slide. So the picture on this slide on the right is of our brand new dental van. It was just launched last February, replacing the original one. The van is staffed with a full-time dentist, 2 assistants, and the program manager. And that small team has been able to accomplish amazing things, as you can see from the results on the slide. Each taxi visit typically runs for 1 week. While on site, they provide comprehensive dental services. The staff begin the week by screening and applying fluoride varnish to all the kids that have a signed packet. And obviously, we see all kids, whether they're insured or not insured, whether it's state insurance or commercial insurance. The team schedules kids by prioritizing anybody in pain or who have been identified with severe needs. And the care. Being on site at a school lends itself to efficiency. If a scheduled kid is absent that day, the team just moves on to the next child. There's no disruption due to no-shows or cancellations. We were really lucky too during COVID, especially because of those relationships that we've built really through OEA Choice Trust, that when schools were when they went back to school, a lot of the school-based sealant programs, like the one I talked that we do, when I referenced before, they could not get back into schools for very understandable reasons, with social distancing and everything. But the great thing about the tooth taxi, the schools trusted us. We had our own offsite, enclosed clinic. So we were able to continue providing services during that time. And to date, you can see the amazing results, and a staggering almost $9.5 million in the total value of services provided. The map on the bottom really needs to be updated. There are so many locations that are not yet represented, but I still like to include it when I talk about the tooth taxi because it's just a great visual to show the statewide reach. When it was retired, our original van had traveled the equivalent of over 3 times around the circumference of the earth, all within our state borders, which is pretty amazing. They are a very dedicated crew. And you can go to my next slide. So the team often receives notes like this from kids. The interior walls of our van have tooth-related artwork all over that kids share during our visits. School faculty and staff, they come on board and tour, and they have been incredibly supportive of this work. They often help identify kids with dire needs, but whose families hadn't completed and turned in the consent packet. And they often reach out directly to those parents or help us connect to get the paperwork filled out. So it really is just a tremendous partnership from each of the entities. And you can go ahead and go forward one more. And that is my presentation. I would welcome any questions from anybody. Awesome. Well, I wish Emily.
Yeah, thank you for that super informative presentation and, describing the links between diabetes and dental care and just impact on A1C3. So that was really informative. I was just going to ask, you said that some of the kids were 4 times as likely to have lower GPA due to tooth pain. Is that national or is that local Oregon data?
That was a California study. So that was
California.
Specific to California. Yeah.
Okay. I
I don't know that
we should
anything
explore that
yeah.
in
It would be
Oregon.
wonderful. Yeah.
We don't have
anything
fluoride in our water, for example.
Exactly.
Okay.
We are a
Thank
very
you.
high risk state. Yeah.
Yeah. Thanks.
Thank you, Dr. Barrichello. And it's a good thing to bring attention to, Emily. Appreciate the work that you do and also the presentation. Any more questions before we move on? Thank you. And my apologies for my mispronunciation of your name. I'll try to do better. Next, we have Kaiser Permanente, Dr. Daniel Pilstrom.
Pilstrom, good job.
Thank you.
Hi. Hey everybody, Dan Pilstrom, general dentist with Kaiser Permanente Dental, and I'm our chief dental officer with Permanente Dental Associates. And I too am going to talk about KP Dental and innovations and update you guys on the board. So again, let me know if you have any questions as we go along. I've been with the group for 20 years, so I've seen tons of innovation and got some exciting things. It's one of the things I think that has kept me energized about my career here. But let's go ahead and advance the next slide. Here's our agenda. We're going to talk about access and service updates, some of the technology we're using to making an appointment easier, and in our journey with online appointing. I'm going to talk about medical dental integration and specifically how we at Kaiser Permanente, as a dental program within a integrated health system, how we use nurses in our dental offices and how we approach medical dental integration in general as it relates to PEBB. And then something exciting and new, Kaiser Permanente Northwest just recently opened their Center for Black Health and Wellness, and I'm going to talk a little bit about how the dental program is working with them to figure out how we can serve these patients within the dental space. Next slide. So we measure access by the percent of members that have been seen within 10 business days of their due date or when they requested the appointment. Right now, we're at 53% of our members have been seen within 10 business days. That's up from last year. We were at 48%. Still not where we want to be in terms of access. Of course, we have availability of emergency visits, same day or next day. That's not an issue of getting in. And we think we've seen some good improvements as a result of hiring a lot more staff. This last year, we hired 37 dental hygienists and 47 dental assistants. And that led to almost 10,000 additional visits across the program, about 4,000 additional hygiene visits compared to 2023 and about 2,300 additional general dentistry visits. Still got a ways to go with hiring. It's been a challenging environment to hire staff, dental staff, but we keep working on that. We've redesigned our hygiene daily schedules, and it essentially is resulting in our staff being able to see about one additional patient per schedule over the course of a year. That's pretty significant. We're anticipating about 22,000 extra dental hygiene appointments for 2025, which will really be great without hiring additional staff. So staff are really working hard to really meet the needs. And something I'm really proud of personally is when patients get in and see us, they really like us. We have consistently scored really high on Google star rating, 4.8 out of 5 stars. Next slide. And just some of the ways, I've showed you this before, some of the ways that we try to make the care easier for patients. I'll specifically go over our online appointing and teledentistry. Teledentistry to us means telephone access. It means being able to email us. It means being able to contact us on kp.org. And we have a lot of our members reaching out to us in that way. So we're going to continue to work on how we use technology for patients to make it easier to get in and talk with us, to make appointments, and to consult with us and get advice. Next slide. This has been our journey with online appointing. And, it's patient expectation these days among a lot of health systems, especially in the medical side, that they can pick up their phone in the middle of the night when they can't sleep and remember that they need a dental appointment and try to schedule that. So about 14% of our appointments this last year were initiated online. And this is a trajectory that is going to continue over the next few years. So we're excited about that. It makes a lot of sense for patients, and it's just the way that consumers are making appointments these days. And we don't see that changing. So we'll look forward to offering that. It's not so easy in a procedure-based practice like dentistry to get the right people and schedules and times all in a system that works well. But we've really made huge strides, and we'll look forward to doing more in the coming years. Next slide. So this is our footprint for those of you who kind of maybe new. We have 21 offices across Southern Washington and the Willamette Valley, 160 dentists, 191 hygienists. We offer service and care, service and advice 24/7. We do offer teledentistry services. And then you can see on that map, there's this icons of these people with stethoscopes. These are our offices that have licensed practical nurses. What's different about Kaiser Permanente Dental is that we exist within integrated health system. So that has a ton of implications. All of our offices are quote unquote integrated. I have the same medical record as the family physician does or as the specialist does. I have the same medications and allergies and problem lists that the physician does. We're not working off of paper forms to intake people to remember those things. It's amazing as a dentist to practice in an environment like that. And because of the focus on population health within Kaiser Permanente, we also do a ton of work around making the dental office kind of an extension of primary care. And this is how the nurse comes into play. When we have nurses in our offices, they can do things that traditional dental staff can't. For example, test patients for their blood sugar. Patients who have diabetes need to get their HbA1c taken on a regular basis. And a lot of times it's not very convenient to go into the medical office to get it, but they're coming in anyway to the dental office. So after they see me for their dental checkup or exam, they go see my nurse and she'll do the blood draw. Or at Kaiser Permanente, one of the, I think, wonderful things about it is that me as a patient, I know what my care gaps are. So for example, maybe I'm due for my colonoscopy. Well, I'll get a report about what care gaps I'm due for. And these nurses are really great in helping patients, like, for example, schedule or provide a vaccination, or even advise patients if they're struggling with their hypertension. They'll take blood pressure and then even communicate with the primary care doctor about if it's elevated and if things need to be adjusted or they need to be seen. So it's really amazing to have those nurses in the offices. Now, our other offices are similarly integrated, but in a different way. The way we think about our offices is different tiers. Tier 3 is offices with nurses. Tier 2 is an office, a dental office that is on the same building as a medical office or medical campus. And Tier 3, I'm sorry, I'm getting it reversed. Tier 1 is standalone offices. Tier 2 is co-located. So they're in an office with the medical building, and Tier 3 is with the nurse. And those different levels of integration allow us to do different things to get the patients into the health system because we view the dental visit as a touch point into the health system. New for this year is we've added an additional licensed practical nurse at our grand office, which was traditionally a standalone office. So they're able to do a lot more to help patients close care gaps and get them back into the health system if they haven't seen their primary care doctor in a while. Next slide. Kaiser Permanente has recently opened their Center for Black Health and Wellness. And that's to focus on the total health of African-American patients who experience more chronic health problems, including oral health problems, than other patients do. And we see that regardless of income and socioeconomics. So, we're really working on trying to figure out how do we improve the equity of the care that we're providing at Kaiser Permanente, and designing a center like this is one of the ways that we hope to learn more about how to care for African-American patients who experience more health problems. On the dental side, it's primarily a medical office. It is a medical office staffed by, I think, 3 primary care doctors. But what's different is that we've built some dental streams of work that can funnel those patients into our dental offices if they have Kaiser Medical and Dental. We also have a dental health questionnaire for all those patients that are being seen in the Center for Black Health and Wellness, so that if they have, for example, MODA dental, they can help that member contact their service provider to get seen if they don't have a dentist or if they're having trouble being seen. We also, because it's Kaiser Permanente and we have our own dental program, we've got lots of patient education and things we can do to offer all of those members. But then again, patients who mention that they're having oral health problems that have Kaiser Dental will get essentially a way of appointing easier into the system. So we're really trying to understand how this might help improve care delivery for patients visiting the Center for Black Health and Wellness. Next slide. And here is our dashboard for PEBB. You've seen this before. I'm going to hit a couple of the highlights. So that middle box on the top, your members utilizing co-located offices, that's that tier 2 setting where the dental office is at a medical office building. And that's important because those members we know are more likely to get their care gaps closed. If they show up at their dental visit and they need their teeth cleaned, but they also need a blood draw because their doctor wants to check their cholesterol, they can go downstairs and get their lab drawn. The dental team's role in that is to remind the patient that they're due for that care gap and how to get it closed in that medical office building. And we see that that's an important difference than patients that are seeing a standalone dental office, a Kaiser dental office, where we can just remind the patient that they have that care gap. Below that one, your members' top 5 care gaps closed, and this is specifically talking about your PEBB members that have seen a nurse during 2024, and you can see they get a lot of immunizations, which is really great. The more barriers you can reduce to getting your vaccinations, the more uptake you see in patients receiving those things. Flu is horrible right now, and so getting patients just flu shots in the fall is a really important thing. Our dentists provide flu shots in the other offices where we don't have nurses. They're able to do that in the state of Oregon. But having nurses provide immunizations to patients, the whole slew of immunizations that patients need, is really a value. They do a lot of lab tests. You guys and PEBB members had about 176 cancer screenings. So this might be an at-home fit kit, which is a colorectal cancer screening, or scheduling a mammogram or something like that, where they can schedule that. What else? On the lower left, your members with 1 or more medical care gaps closed. So we track if a member came into a dental office and then they had a care gap closed within, I think it's 60 days. We try to attribute that care gap closure to the dental. Now they're going everywhere. They're going to optometry, they're going to podiatry, they're going to their primary care doctor, and they're all getting those care gap reminders. So there's all these opportunities to help that member close their care gaps, and dental is part of that. So a standalone office, that's their role, is to remind patients like, hey, you're due for these care gaps. This is how you can get them closed. This is why it's important for your overall health.
Excuse me, Dr. Pilstrom.
Yes,
Thank
please.
you very much. I'm sorry. I need to call your attention to our time.
Okay.
Oh, yes, we're running behind. Thank you. Thank you. That's a beautiful presentation about some of the ways we can integrate care. I'm going to ask our members to hold their questions for now, but if you could go ahead and close it up. I think this was your last slide. Am I correct?
Yes, it is. But I'm not driving the slide deck, so.
Next slide, please. Perfect. Thank you for that, and my apologies. We need to move to our last presenter, and And Willamette, my apologies for having us running late.
No problem. Good afternoon. We'll try to make this as quick as possible, but still be informative for all of you guys. So good afternoon. My name is Tiffany Nicholson, Manager of Client Services. And with me today, I have Dr. Mark Chambers, and he's our Director of Doctor Development. So just quick agenda today, go over some access and service updates, and then we'll talk about Willamette Dental and our current approach to innovation. So next slide, please. So we were asked just to give a quick update on access. Our current average access time for 2024 to date is 24 days for Oregon and Southwest Washington offices. This does exclude emergency appointments. So those appointments are always going to be available within 24 to 48 hours with on-call triage available 24/7. Throughout this year, we've also been very busy trying to fill some open positions. So to date, we've filled 81 clinical positions, which includes 15 dentists, 18 hygienists, and 48 dental assistants across our 3 states. So just a quick update on some geographical areas. Currently, right now, we are recruiting 1 provider for our Grants Pass office. We do have our Medford providers covering. So at this time, those members are being placed on a callback list if appointments are not available. So we've been heavily recruiting for quite some time. Just recently, we do have some increased candidate attraction, which is very exciting, but we're optimistic that that will pan out, but I don't have anything official yet, but hopefully we will get to secure one of those candidates, and then we'll be to share to update those things as soon as they're finalized. Next slide, please. So innovation is one of Willamette Dental's core values, central to our decisions, strategy, culture, and then also our daily operations as an organization. So we embrace change and we encourage invention amongst our teams. So we're going to just do a quick update kind of on our dental innovation that is exciting to share kind of what we are and have been working on with you today. So next slide. Teledentistry, so common topic, brought up by both of the other dental carriers as well. So can include patient care and education, delivery using but not limited to multiple modalities. So synchronous being a live 2-way interaction, asynchronous where there's transmission of information. So think radiographs, photographs, digital videos, digital impressions, things like that. Mobile health, which was talked about. So there's been lots of technology advances that have expanded options for dentists to communicate with their patients. The benefits of teledentistry could include increased access to care and then expanded delivery for necessary dental care as well. And on the next slide, we'll kind of talk about teledentistry at Willamette Dental. So at the start of COVID, we did utilize teledentistry in different forms. It's kind of pivoted over the years in different ways to utilize the service method, but ultimately offering teledentistry appointments in the beginning was not proven to be notable successful. Just the benefit of replacing the quality care available in the office didn't quite match up with a full teledentistry service. Now, however, there is a continued ask for teledentistry. We are committed to exploring further dental telehealth in 2025 to find the best platform and services that we can consistently deliver care to the same quality of how we would do in person. Now, we do use different forms of teledentistry currently. For example, emergency triage, our online appointment scheduling that we'll talk a little bit later about as well, but really just looking at kind of a bigger platform to do a full service teledentistry offering throughout the next year. And now I'll hand it over to Dr. Chambers.
Excellent. So on our next slide, sealants. Just want to share with you some of the things we're doing with sealants. In our company mission statement, it talks about preventing the disease repair cycle, meaning that if we can keep a patient healthy, if we can prevent us from drilling into a tooth in the first place, keep the patient from getting a cavity, and the long-term success of that tooth and the health of that tooth is going to be better. There have been studies showing that on average, when a tooth is drilled into, the life of that tooth is going to cost that patient about $6,000 over their lifetime with new fillings and crowns, root canals, extractions, and other treatment associated with that. And one of the ways we can do that is encouraging sealants with our patient population. We see a 80% reduction in cavities after 2 years after a sealant is placed, and a 61% reduction after 5 years with sealants. Sealants do come out, and that's part of the reason that as patients come in for exams and checkups, we're always monitoring those sealants and sealing those teeth as needed. With the Willamette Dental plans, there is coverage for sealants regardless of the patient's age, and covered 100%. On the next slide, we had an article that was published in the Journal of American Dental Association this last May, and several of our clinicians were part of this, and it looked at using a decision support tool built into an electronic dental record to encourage prevention. And it showed that over time, we were able to increase utilization of sealants by 27% at the beginning of the study. And over the course of 4 years and 59,000 exams during that time, we were able to see the utilization increase up to 60%. And again, this was published earlier this year. I checked this morning. Currently, we're at 79% as an organization. So we continue to trend up. We'll continue to work with our providers on doing that. Just as a comparison, the national average for children between the ages of 6 and 11 that have sealants is 41.7%. So we're continuing to encourage prevention. On my next slide, we talked about dental radiographs. We follow the American Dental Association FDA guidelines on frequency of x-rays, and with those guidelines, they recommend that the interval is tailored off of the health and risk of the patient. So we do risk assessments on each patient. With digital x-rays, when dentistry switched to digital x-rays, and I think you probably noticed that all of your dentists have probably switched to digital x-rays by now, we saw an 80 to 90% decrease in x-ray radiation to a patient. There's also been a change in dentistry, switching to rectangular collimation. So it's a little collimator that's put on the end of the x-ray unit, and that will decrease x-ray radiation to the patient by an additional 70%. We use rectangular collimation through all of our clinics. Currently, if you look at utilization in dentistry as a whole in the United States, currently rectangular collimation is only being used by 20% of dentists in the community. But another kind of interesting change, and you'll probably notice it when you go see your dentist, they're likely not going to be putting a lead apron on you when you have x-rays taken. And that was a recommendation that changed this last year from the American Dental Association as well. We're always working with our providers to make sure we're calibrated and on the same page. If you'll skip forward 2 slides for me. Thank you so much. Antibiotics in dentistry is a hot button topic. Medicine has always a little bit further ahead of dentistry, and medicine's worked on trying to decrease antibiotic usage in situations where it's not needed. Right now, dentistry prescribes 10% of all antibiotics that are prescribed in the United States. And there have been some recommendations to decrease antibiotic usage in dentistry. On the next slide, we have currently a joint study that we're doing with several universities and dental schools, looking at prescription guidelines from the American Dental Association versus what providers are currently doing. And we hope to have that published here soon, but essentially looking to calibrate and get the dental community all on the same page and practicing appropriately. My next slide is 3D printing. To just touch on this, we've converted over to 3D printing for our orthodontic appliances, dentures, and crowns. We're at 85% of our crowns are 3D printed now, using digital impressions. 52% of our dentures are, and we're rolling this out next year to increase that number, and 92% of our orthodontic appliances. We find that the quality is significant, the fit is better, and the turnaround time is significantly better, getting those appliances back to the patients in a more timely manner. If you'll skip forward to 2 more slides. This is our last slide. Just that we also have a new online scheduling tool. It's being launched, or it was launched in 2024. This last summer, it allows patients to be able to schedule online and come in for the appointments. There's been great feedback from the patients. They appreciate being able to cancel and set new appointments and do that. But we sure appreciate you taking time to hear from all of us today. Any questions anybody has?
I'm not seeing any, and I am cognizant of the time. I'm grateful for your grace in presenting and for the work that you do delivering care across the state. Thank you very much for your presentation, Dr. Chambers.
Thank you. Appreciate you guys.
Rose, do we have any public comment, please?
No, no public comment.
Thank you. Anything else for the good of the order?
Don, this is Ollie. Just one thing quickly. We'll be sending out an email asking for another participant to join Greg and Andy on the Seattle committee that meets jointly with OEB, but more detail to come. And I just wanted to wish everyone happy holidays and thank you. Great work today. Excellent job of moving this RFP forward, and that's exciting. So thank you.
Thanks,
So good to see
Ellie.
everybody.
It's a pleasure. I wish everyone a safe and happy holiday season this December and January with loved ones. Take care of yourselves, everybody. Thanks for the collaboration.
Thank you. Merry Christmas.
Bye, everybody.
Happy holidays.